Good morning, everyone, and welcome to this very, very important CME on conservative management of prolapse. I think we are very lucky to have all the stalwarts of urogyne today. And Dr. J.B. Sharma is there, Dr. Amita. And
led by Achla.
Dr. Ranjana, and everybody. So it's good to see everyone. And I think before I talk about this, I think let us all congratulate Amita for getting representing urogyne from India in the international forum.
Thank you, ma'am.
That's a great achievement for all of us. So conservative treatment of prolapse is a very favorite topic of mine, and it is very important because every woman who has any degree of prolapse does not mean that she has to have a hysterectomy. A general answer, if you hear from anybody who's a general doctor or a general gynecologist, not very well versed, if somebody comes with prolapse, whatever may be the age, whatever may be the degree of prolapse, the one treatment which is offered is you have to have a vaginal hysterectomy. So we have to do away with this, conception. And we all know that we get very good results with just exercise also in the mild degree of prolapse. And the pessaries, which now that there has been a revolution in pessaries, we had very hard pessaries which will break, which will hurt. We have very good pessaries now. And I have patients who have their prolapse reduced, symptoms reduced with the pessary, and then they over a period of time, there is a decrease in the prolapse also. There's narrowing of vagina also. And sometimes patients are not able to understand our exercises. So there is availability of biofeedbacks, very simple biofeedbacks now, which helps them to understand the exercises. So everybody should know all about it and not rush to surgery for not only prolapse, even in cases of mild incontinence, stress incontinence, just the lifestyle management and exercises can help these patients. So congratulations, Geeta, for having chosen this topic. And I think everybody is really going to benefit from it. And I hand over to you for, starting the session.
Thank you, Dr. Achla. Thank you. Dr. Renuka, can you proceed with the session?
Yes, ma'am. Thank you, Achla, for your nice words and for being a constant support of our urogyne subcommittee. Now I will start the session 1 of today's webinar. And to chair this session, I would like to invite Dr. J.B. Sharma. Sir is currently working as a professor at AIIMS, New Delhi, and he had been ex-professor Maulana Azad Medical College, New Delhi. He has been awarded with the prestigious Dr. B.C. Rai Award in 2015. He has published more than 350 publications he had more than 350 publications in national and international journals. Dr. Ranjana Sharma, ma'am is Senior Consultant Obs and Gynae, Urogyne and Laparoscopic Robotic Surgery, Indraprasth Apollo Hospital and Apollo Cradle Hospitals. He is Chairperson AICC RCOG New Zealand 2020-2013, and he has been MRCOG examiners. Dr. Harsh Khulla, ma'am, she is Senior Consultant Sir Ganga and Vice Chairperson Sir Gangaram Hospital, Obs and Gynae, and he has worked as Senior Consultant. He has been Secretary AOGD from 2008 to 2009 and ex-Joint Secretary IMS New Delhi branch. And Dr. Chandra Mansukhani, she is Senior Consultant Obs and Gynae at Sir Gangaram Hospital. He is in charge of Adolescent Clinic at Sir Gangaram Hospital. He is Vice President ISOPAP Delhi chapter from 2013 to till date. Now I will invite Dr. Ranjana Sharma to invite the first speaker of the session.
Good morning, everybody. And thank you, Geeta, for giving me this opportunity to interact with so many stalwarts here. And I must congratulate Amita for taking this prestigious post. And we have high hopes from you, Amita, now. Yeah. And Geeta, really congratulations on choosing such an important topic in urogynecology. And I think, the success of conservative treatment is directly proportional to the commitment of the provider and of the user. So a lot of this conservative treatment needs, what it needs is like, passionate people like you and so many of us, who are committed to the conservative treatment and convinced that it will work. When you are convinced, it surely will work. So Geeta is a senior consultant in the Department of Obstetrics and Gynecology, Sir Gangaram Hospital. And we all know her passion, dedication to urogynecology. And so her special interest is urogynecology. And she is currently the editor of AOGD Bulletin. And she was a bulletin editor in 2021 and secretary of Delhi Menopause Society 60. So she's had so many important posts. All of us know Geeta's passion for urogynecology. So I'm not going to, stand between you and her presentation, which is on vaginal pessary, indications, devices, and approach to selection of patients, which is really so important. So Geeta, the stage is yours. Thank you very much.
Thank you. Thank you, Dr. Ranjana. Renuka, can you stop sharing your screen?
Ma'am. You please share your slides, ma'am.
Yeah. Okay, I'm sharing my screen now.
So we know the
Can
past.
you see my screen?
Yeah.
Dr. Ranjana, can you see my screen?
Yes, I
Yes,
can.
ma'am,
we
we
can
can.
see your
We can.
slides,
Yeah,
ma'am.
so at the outset,
Please
I
go
would
ahead.
like to thank everybody for giving me this opportunity, and thank you, Dr. Achla, for the encouraging words from Dr. Ranjana, Dr. JB, and all the stalwarts here. And as Dr. Achla and Dr. Ranjana pointed out very appropriately, there is a big role of conservative management of prolapse and SUI. Everybody doesn't need the knife. So today I shall be talking about the indications, the various devices we have at our disposal, and the approach to selection of patients. The outline of my presentation is as follows. First, I will talk about the general principles and the mechanism of action of pessaries. Then the evidence for efficacy of vaginal pessary in SUI and pelvic organ prolapse. The indications and contraindications of using pessary. Then in the second half, I will discuss about the approach to patient and selection of patients and the various devices we have. Now, coming to the general principles, it's a no-brainer that, pessaries are very useful. And if you see the physics of it, basically prolapse is a hernia. There's a pelvic floor defect. And because of that, there are functional sequelae like SUI, difficulty in voiding, difficulty in passing stool. So pessaries basically provide support to this hernia, including the anterior, posterior, the apical, and the combined sides. The pessaries are held in place proximally by the uterus or the apex if it's a hysterectomized woman. Laterally, they are held in place by the levator muscles, and distally, it is held in place by the pubic bone and the introitus. Now, the mechanism of action, to continue that, it is in SUI cases, it is related to the improved urethral function. Now, very elegant urodynamic studies have been performed, which have seen that there is an increase in the functional urethral length and the urethral closure pressure. There is absence of urethral obstruction. At the same time, there is no obstruction to flow. And there is resolution of the DI in women with severe prolapse and DI. And anatomically, and the MRI studies also, they have found when they did MRIs of these women, they found there was an improved urethral support and there was a reduction in the straining Q-tip angle. And also the decrease in the posterior uretrovesical angle and elevation of the bladder neck, thereby increased urethral length, which helped in treating the urinary incontinence. Now, in efficacy of the pessary in pelvic organ prolapse, now we know that they are commonly used as first-line therapies for symptomatic POP and SUI, but supporting data are very limited. So there was this very elegant meta-analysis which evaluated the efficacy of Pessaries for pelvic organ prolapse. And only one trial was found which reported similar symptom improvement for both ring and Gallant devices in 134 women. And both were effective in approximately 60% of patients who completed the trial. Now, as far as the efficacy of these pessaries in SUI, it was a very nice study by Kandif et al., where they were unable to reach a conclusion regarding the benefit because the different comparators were used, different devices types were used, different outcome measures were used. So there was no exact conclusion. But 3 other small trials suggested that Pessary might be better than placebo, but again inconclusive because of the small sample sizes. Numerous other studies have compared Pessary use versus pelvic floor muscle training and surgical correction. And they found that pelvic floor muscle training in SUI, of course, requires more time, but it has no adverse effects, whereas Pessary requires less time, but associated with erosions, maladdress, vaginal discharge, etc. So they concluded that for as far as SUI is concerned, PFMT takes the prize, and that's better than the continence Pessary. Now, the highest quality data regarding this issue are from the Atlas trial, that was the ambulatory treatment for leakage associated with stress incontinence, and they randomly assigned 446 women with SUI to either a continence Pessary, behavioral therapy and other strategies, or a combination of both Pessary and behavioral therapy. And of course, a higher number of women in the combined group were more satisfied and were also reported complete absence of bothersome incontinence symptoms and happier with the treatment. Now, these outcomes did not differ significantly between the behavior and the combined group. So, in women with pelvic organ prolapse, Pessary use combined with PFMT improves the pelvic organ prolapse symptoms more than PFMT alone. Now, let's see the clinical scenarios which Dr. Achla very rightly pointed out in her introductory lecture, that which are the scenarios where the Pessary is indicated, and rightly so. So, first is a patient preference. I have put it on top because that is a very important point to note. Many people do say that, look, we don't want any surgery. We want to try Pessary. So they have full right to demand the gynecologist for this, and it is our duty to respect their preference. So first is a patient preference for a non-surgical treatment. Of course, counseling is very important at the same time. Then presence of severe medical comorbidities that make the patient a poor surgical candidate, that is a no-brainer. Obviously, we will try a Pessary for such patients. There are some scenarios where the patient is waiting for their children to arrive from abroad, or they're arranging the money, etc. Or there is some personal reason they want to delay surgery for several weeks or months. They are a good candidate for an interim Pessary treatment. The fourth category is a patient who has a recurrent pelvic organ prolapse or SUI, and patient preference is for avoidance of a repeat surgery. That is, patient has had a prolapse or a SUI, and it's a recurring theme, and she doesn't want to have a repeat surgery. However, you have to counsel these women that this is a risk factor for failure to fit a Pessary, of course. The fifth candidate is a woman who has severe ulcerations, a severe decubitus ulcer with a huge pelvic organ prolapse. So reducing the prolapse with the Pessary and application of vaginal estrogen cream, this promotes the healing of ulcers within 3 to 6 weeks, and also reduces the congestion in the vaginal mucosa, which is very useful to the surgeon at the time of repair. And another important component is the pelvic organ prolapse in a current pregnancy. Now, this is a very important indication. In Lady Harding, I remember we used to see a number of these women who used to benefit with the, of course, in those days, there were those ugly looking rubber ring Pessaries which we used to put. But anyway, they were a good option for such women who are pregnant and having a prolapse as an interim treatment. Then another category is the patient has a desire for future childbearing, and she has a prolapse right now. So they have to be told that if we repair you now, that will be nullified by the subsequent pregnancy childbirth. So better wear a ring Pessary or a support pessary, have your next baby, and thereafter consider surgery. So these are about 7-8 options or categories of patients which all of us, all PGs should remember who are candidates. Now coming to the contraindications, when you will not use a pessary. Of course, if there is a local infection, you will first treat it, then fit her with a pessary. Or patient has an exposed foreign body or a neglected copper IUCD, or there is a exposed mesh, a TVT or a TOT mesh which is exposed, then obviously you will not fit them. A patient has a latex sensitivity. Of course, we have got very good pessaries, silicone pessaries right now, non-allergenic hair, durable hair. So we can use in those cases. Then non-compliance. Patient is maybe mentally suboptimal IQ. Then of course, she will not comply. Or a patient is sexually active who are unable to remove and reinsert the pessary. So it's very important for us to know that the patient acceptance in various studies which have been quoted varies from 42 to 100%, and it is basically majorly related to appropriate counseling, majorly associated with encouragement from the provider. And patients who decline a pessary trial are likely to be a young nulliparous lady or someone who has a severe degree of prolapse and incontinence, and she's really miserable with it. So these are the candidates who will probably refuse a pessary. And usually an older woman with a lighter prolapse will prefer a pessary. Now, our approach, let us see how when we deal in patients, how we evaluate a patient vis-a-vis the history, examination, and the symptoms. So here I would like to say that history is very important to understand the patient's bother symptoms. What is bothering her more? What are her concerns? What are her goals? And how much is she limited? How much is her activity limited? If she is severely limited, then and if she is having a big prolapse with an ulcer, it is better to put a pessary, heal the ulcer, and go ahead with the surgery. But if the patient is, an active athlete, doesn't have time to undergo surgery, she can be fitted with a pessary. Then physical examination is very important and to exclude any pathology and to understand the pelvic floor anatomy. If she has a very big distension or a displacement cystocele, displacement cystocele would rather benefit with a pessary. But if she has a big distension cystocele, then the pessary may not help her too much. Also, we have to focus on the urinary symptoms, whether she has any voiding difficulty, any recurrent UTIs, any overactive bladder, any bowel symptoms like defecation difficulty, incontinence, constipation, any bulge, heaviness, discomfort, etc. So they will help us to categorize the patient as a pessary candidate or a surgery candidate, of course, after due counseling. So this is just an outline showing the various pessaries we have in our armamentarium. The most commonly used are the ring pessaries, and the less commonly are the Schatz, Lever, and Gerum pessaries. Then after the support pessary, we have the next group of pessaries which are called space-filling pessaries. That is, they occupy more space than a ring pessary, like the gallon and the donut pessary and the cube pessary, the inflatable ball, which I'll show you the pictures shortly. And then you have the other group of the incontinence pessaries. The most commonly used are the incontinence ring with the dish or the impresso incontinence device. And the less commonly used ones are the bell-shaped incontinence pessary and the cylindrical intravaginal device. So this is the box, fitting box, which we have. And we can autoclave, as you can see, there is one pessary which is being number 6 pessary, which is lying autoclave. This we make the patient wear for 15 minutes, walk around in the OPD, and then fit her. So this is a fitting box we have. And they are of various shapes and sizes and different types. I'll tell them one by one. And currently we have got beautiful pessaries made of silicone, non-allergenic, durable, autoclavable, and they don't retain odors also. A few others are made of latex or polycarbonate, but majorly silicone. And therefore you must ask the patient about the silicone allergy, the latex allergy before fitting in these pessaries. And very numerous surveys of gynecologists and female pelvic medicine specialists and recurrent constructive surgery specialists have reported that the ring pessary was the most commonly used pessary by them, followed by the gallon pessary. Now, as I said, the symptom cluster, which helps us to guide. It's a very, very broad slide I have made just as a rule of thumb, that you must know that support or space filling pessary can be used for prolapse with or without urinary or bowel symptoms. And in general, the support pessaries we reserve for women with stage 2 or early 3 prolapse, whereas the space filling pessaries can be used for women with advanced stage 3 or 4. And as you can see in this slide, the ring pessary, this is a ring pessary, folding pessary for mild prolapse. And this will fit almost, you can say 70% of your women. It is the most commonly used pessary. And it is also comfortable, easily removed and inserted by the patient herself. Even sexual intercourse is possible when it is left in place. As you can see in the diagram, it fits snugly up and it should be tucked into the vagina, high up gulfitic to avoid soiling with urine and feces. And thirdly, the ring without support, this is the one that I'm showing without support, is very useful in younger women because they have less atrophy of the levator muscles and a more oval contour of their vaginas. So absence of the support diaphragm allows this pessary to take an oval shape and conform to the shape of the vagina. As you can see, there is no support in this picture of this ring. Compare it with this pessary. Now this is a ring with support. There is a ring and there is a diaphragm, thin diaphragm across the ring. And this one is especially useful in women with prolapse and or a small cystocele. And it can also be very useful in patients with a rectocele and even a vaginal wall prolapse. And usually size 3, 4. Now here I'm showing you size 2, 3, 4, 5, 6. The middle ones, the 3, 4, 5 are usually considered appropriate for most of our patients use this thing. Now, coming to the other type 1, there is a patient who has a prolapse and SUI. Now, what do you do? Now, as you can appreciate in this picture, these are also rings with support, and there is a small knob there. You can see there is a small knob, which is called an incontinence knob. And if you see in the lower picture, that incontinence knob fits at the urethrovesical junction to give it a support and increase the urethrovesical angle and prevents SUI. Stress urinary incontinence. Now look at this one. This is a gallon pessary and this is a space filling. The other one was the support. This is a space filling pessary. They are essentially 3-dimensional and differ from the support in that they have a large base that supports the vaginal apex or the cervix if the uterus is in situ. And you can have, this is the gallon which I'm showing, and I'll show you the donut, the tube inflatable ball shortly. Now they are particularly useful in women with severe prolapse, 3 or late 3 or 4 prolapse, very useful in post-hysterectomy wall prolapse, but they have no advantage vis-a-vis treatment of SUI is concerned. So that is one disadvantage, no SUI. And second disadvantage is that intercourse is not possible when patients are using this. So as you can see, the gallon has a broad, firm circular base. It has a stem protruding from the center, and this broad base, as you can see, provides support to the apex, and the stem sits in the long axis of the vagina. And this stem keeps the circular base, as you can see in this picture, the stem keeps the circular base from rotating into the long axis of the vagina and being expelled. The base, as you saw, was a little, as you can see on the left-hand side, it is a little concave. So this is allowing the suction to form against the vagina, which helps to hold the pessary in place, as you can see in this picture. But it sometimes is difficult to remove it. And there are small holes, as you can see in this picture. There are small holes in the base to allow the drainage. And the hole in the stem is also there. And again, they are available in 2.5, 2.75, 3 inch. We have a whole collection of all sizes which we use to fit. Now, the advantage is it is very useful for larger prolapses. It reduces the, as you can see, the upper part is resting on the posteriorly, so it helps to reduce the rectoceles and related symptoms, and it retained by the patients who have a wide genital hiatus. Now, coming to this other space filling pessary, which is the donut pessary. As you can see, it is like a donut. This is also a space filling pessary. It is like a ring pessary, but this ring is very thick and hollow. This thick and hollow ring fills the large space associated with advanced prolapse and very useful in women with very atrophic levator hiatus. So this is also available in, like the gallon from 1 to 3 inch sizes in 1/4 inch increments. And usually you maybe a 2.5 and 2.7 or a 3 inch will be sufficient to fit this. And this is especially useful in whom gallons have failed. And the way to insert this is to hold it vertically and then you push it into the vagina and then you rotate it to a horizontal position during placement. Sometimes you can use a Kelly's clamp to remove because it fits in very nicely at the apex. As you can see, it is fitting very nicely at the apex. So it's very useful for prolapse, precedentia. You don't have to deflate it. And the third type space filling, I told you gallon, donut, and this is my third type of pessary which I'm showing you now. This is a cube pessary. Now cube, as you can see, it has 6 concave sides and as in the letter H. And in the picture, you can see the tube holds the vaginal walls with suction. So it prevents the prolapse and it is also available with holes which have been theorized to reduce the risk of erosion. And it is highly useful in correcting prolapse, early prolapse as well as late prolapse. But the only problem with this is that this has to be removed every 1 or 2 nights, cleaned nicely, not to be reinserted till next morning to prevent vaginal injury. So patients who are unable to remove their pessaries every 1 or 2 nights are not candidates for a tube pessary. And also the risk of a neglected tube is very, very high compared to other pessaries, because even short-term use, if you leave it neglected, is related with vaginal erosions. And there was one case report I was reading where a rectovaginal fistula was also reported. Also, there is a report with this tube is associated with a lot of malodorous discharge. So this pessary is an option for only a very motivated, for a very compliant patient who have failed the gallon and the donut pessaries. But it has to be a very motivated and compliant patient. And how it is fitted? It is fitted by squeezing the flexible rubber sides together and placing the device at the apex, as you can see in this picture. And usually they have a diameter of 0 to 7, but usually 1 to 2.5 inches is more than enough. And in this left side, right side is the cube, and in the tandem cube, you can see that 2 are placed in tandem. So, but they have to be removed every night. Now, next comes to the inflatable ball. Now, inflatable ball is also used, again space filling pessary. It is again used for 3rd degree prolapse or precedentia with or without a mild cystocele. Now, here the inflatable ball pessary was designed to facilitate removal and insertion by the patient herself. It has an air-filled ball, which you can see, which is attached to a stem with a port. And this port is used to inflate the pessary after insertion and to deflate the pessary once it is being used. And this makes the device less bulky during insertion and removal. So, but the stem which keeps protruding, that is a problem, sore point with the patient, because the patients sometimes find it unacceptable. Also, this is made of latex, not silicone. So you have to be remembering that inflatable ball cannot be used in a latex allergy patient. And the method to place it similar like a donut. You attach the bulb and a ball bearing within the stem is moved to a lateral projection on the side of the stem. Then the pessary is inflated. And the ball bearing is moved back into position to keep the, as you can see, there is a ball bearing which moves up. And at the time of removal, you deflate it and remove it. And it is available in 2 to 2.75 inches in 1/4 inch increments in their diameter, as you can see. Now, supposing the initial pessary is not successful, many times, this is in fact more common than thought, how do you select the next pessary? It is guided by the reasons for initial failure. So if the initial ring patient says it just dropped out, so just simply try the next larger size and keep increasing the size until the pessary remains in place or the patient is uncomfortable. And if the patient says, oh, my patient is very uncomfortable, then you remove it and put the next smaller size. And if patient has a SUI or a persistent SUI, she will definitely be better off with a incontinence specific device rather than a support or a space filling pessary. And in case a ring pessary continues to come out, then you switch over to a space filling like a gallon, or one who's a very enlarged gaping introitus, then you can move on to a donut or a cube. Now there are other pessaries not very commonly available. That is the Schatz pessary, the lever pessary. This is a Schatz pessary showing you the picture. It is a rigid ring pessary and the same basically as the gallon, but without the stem. That is just like the base of the gallon is there, and it folds minimally and inserted on the diagonal and then rotated to a horizontal position. This concave surface, as you can see, promotes adherence to the anterior vaginal wall and theoretically reduces the risk of slippage or expulsion. The other pessary are the lever pessary. Now, lever pessary is a common name given to the Smith, the Hodge. The one I'm showing you is the Hodge and Rieser pessaries. They are collectively referred to as lever pessaries. Now, they were originally intended to treat uterine retroversion actually in the olden days, but then they were also used for uterine prolapse and cystocele. And they have also been used in pregnancies complicated by cervical insufficiency. But they are hardly ever used because they are very cumbersome to be used at the current moment, because uterus has to be manually anteverted if it is retroverted, and then only they will fit it. And then it is folded and inserted into the vagina. And the index finger is placed against the posterior bar and until it rests posterior to the cervix. And then the anterior bar is shifted to behind the pubic symphysis. So it's a little complicated insertion. They first fit in the posterior one, antevert the uterus, and then the third pessary is the Gerung pessary, which you can see it is like a U-shaped pessary, majorly for cystocele and rectocele. It has a flexible rim with a rubber diaphragm, as in letter D, as you can see in the picture. And when inserted properly, the two bases, the limbs of the D, they rest on the posterior vagina against the lateral levator ani muscle, and the concave surface and diaphragm support the anterior vagina. So there are no much studies available, and it's also very challenging for patients to use this. So now next are these incontinence pessaries. As you can see, this is a ring pessary with support, and there is a knob which I've already told you. This, when, as you can see in this picture, in the lower picture, as you can see, the incontinence pessary, that knob, as you can see in the lower picture, it compresses the urethra. As you can see, it compresses the urethra against the posterior portion of the symphysis pubis. Thereby, it increases the urethral resistance, increases the urethral length, thereby prevents SUI. So it's very useful for this ring pessary with support and a knob for patients with SUI. And again, the fitting sizes are available. And the problem is that this pelvic organ prolapse can be used all day. But if a woman is using this pessary for SUI, you can tell her that you can use it like as a SOS treatment. Whenever, say, she's going for a jog or anything, then she can use it, because if she doesn't have prolapse, if she has only this problem. Now, coming to the incontinence pessaries, we have this incontinence ring and dish, and majorly they are not very commonly used. Then we have this bell-shaped incontinence pessary, which is basically a bell-shaped, like a uresta it is called. It has a handle at its base for easy removal and insertion, and a narrow rounded tip that allows insertion into the vagina. And this wide base supports the urethra, again made of medical grade rubber, extensively tested. And a cylindrical intravaginal device called Pontiform is like a hollow large tampon and made of santoprene, non-allergenic. And again, it's used for cases of SUI. Now, let's see what is the trial of a problem-specific pessary. So in pelvic organ prolapse, if gel-on pessaries are not successful, you can upgrade to a donut or a cube. But cube, as I said, must be removed daily due to the risk of vaginal erosion. And if pessaries fail, then of course surgery is elective. And SUI, of course, the options are to use the incontinence dish I showed you, the ring with the support with a knob. Other options, I've already told you about Impressa or Quantiform, but the jury is out that pelvic floor physiotherapy is preferred over pessary use for SUI. I must convey this message to everyone that it is always preferable to use the PFMT. And if childbearing is completed and conservative measures are failed, then and then only surgery should be elected. Now, coming to the outcomes which have been studied, the symptom resolution, most short-term and medium-term studies have noted improved symptoms in women related with the pessary. After 2 or 4 months of pessary use, they have reported that prolapse symptoms have improved by 70 to 90%. That there is bulge, pressure, splinting is gone. Urinary symptoms, of course, the resolution is much less, 40 to 50% only. Bowel symptoms, even less, 30 to 50% resolution. Sexual function, 40 to 60% reported increased sexual frequency and satisfaction. And 70% said they had to remove the pessary during intercourse. These are the various references from which all these studies have been taken. Now, I came across a very interesting thing which I want to bring to everybody's notice, that what are the various non-symptom related outcomes. You know, they found that anatomically, there were limited data, of course. One study reported that after the pessary use, the patient's genital hiatus reduced after 3 months from 4.8 to 3 point, almost 1 centimeter reduction in the size. And hydronephrosis also improved in 30% of the patients. So compliance with pessary use, the most common reasons to discontinue are persistent incontinence or resolution of incontinence with pelvic floor alone, or a discomfort, or she expels it, or the previous surgery has failed. Now, this is the last slide. What are the complications? As I've already said, erosions, bleeding, extrusion if you have used a smaller size, foul smelling discharge, pain, constipation, incontinence, impaction, and as I said, with tube pessary, few cases of rectovaginal fistula have been reported. Thank you very much for your patient listening.
Dr.
Hello?
JB?
Hello. Yeah.
I'll just stop sharing my.
Yeah.
Okay. Yeah. Thank you very much, Dr. Geeta Mandiratta. You did such a wonderful job, and I think you have highlighted everything about conservative management, especially the role of pessary. In fact, I feel pessaries are a lot underestimated, underutilized in India. I remember working in UK, they were so commonly used. Almost most women used to come every OPD, like, to get the pessary changed. We used to use ring pessary at that time every 6 months. And we still at AIMS are using the ring pessary a lot during pregnancy, prolapse in pregnancy, and similarly in purpurium. But I feel at other times, they are highly underutilized and, less this thing. I think all of us have a role to play, that if we can encourage, we can somehow, the young generation, how to use them more often and this thing. But at the same time, we must not forget, that these patients need follow-up. I remember seeing 2-3 patients, where like she had a pessary and she forgot about it, came after 7-8 years. It was totally buried in, and the vaginal mucosa had grown over it, and we had tough time. We cut it and rotated it to remove it, And we even saw a case of vaginal carcinoma after a forgotten pessary of 20 years in this. So rarely such cases, so the proper follow-up is there. So in fact, I would like, so Dr. Geeta has really almost, it was like an encyclopedic lecture on pessaries. Many of things I have heard even myself for the first time. So we can call it a monograph by her. So I really heartily congratulate Dr. Geeta. So would you like to just give another comment about, like, exactly in translational research in India, which patients are most suitable for them in real practice, and about their complications?
Yeah. So thank you so much for your kind comments, sir. As I said, first take the history, do the examination, see her sexual symptoms, urinary symptoms, bowel symptoms. If it's an early prolapse, maybe POPQ stage 1 or 2, surely she can be fitted with a ring without support. It's the best one. If she has a little SUI, a ring with support, with that flat, thin diaphragm I showed you, that pessary, the ring with the small diaphragm with a knob, she can fit. 70% of your patients will be happy with this. The higher degrees of prolapse, she's very obese, hypertensive, poor surgical candidate, you can give a gallon pessary. These are very good pessary, suction tip attached on top, and that knob sits in the long axis of the vagina. Otherwise, a donut can also be fitted, but gallon is a better option than these space occupying, space filling pessaries. I think 90% will be happy, and especially also this pregnancy group, which we used to see so often, as you know, in government hospitals. They are very well treated with these ring pessaries. The support pessaries. We call them not ring pessary, we call them support pessary and space filling pessary. Support are the ring ones, and also they are, you can choose your patient. And there is in the menu card, like a contraceptive basket, we have a basket of pessaries which majorly will fit most patients. Of course, if they fail, then surgery is always there. But as you have very rightly, and Madam Achla and Dr. Ranjana have said, I think there is a big unmet need for our PGs to understand the role of pessary. That was my main aim of keeping this webinar actually.
And the gel horn is a very good pessary,
Yes.
even in older women with the wide introitus, because it has that suction effect. It is very, very useful. And I have found it very good, in the patients who bring all the rings were falling out, the gel horns really helped. Only thing is, when you send the patient home after fitting, you must tell them about that. If they have any urinary problem, retention, they must report back. That is one problem. Sometimes it happens. Otherwise, pessaries, or the present pessaries of silicone, they do not cause that kind of incarceration or burring into it, because they are very soft and inert, so they don't burrow.
In fact, I was impressed seeing a basket in Safdarjung Hospital. No, Dr. Achla has a big, beautiful basket of all types of pessaries. No.
Yeah.
Yeah, this is the same one which Geeta has shown. The same one is there.
Okay.
Can I ask a question about the pessary care? Dr. Geeta has nicely elaborated, but briefly just about pessary care in daily life.
Yeah. Sometimes so they say you can leave it in situ for about 2 to 3 months, and come for, but initially you have to call her every weekly to see whether there is no malodorous discharge, erosion, etc. See her symptoms, her urinary bowel symptoms, her sexual activity. If all is well, and if she's a compliant patient, intelligent patient, she can herself wash it and refit it. As Dr. Achla said, they are very nice silicone ones. They don't ulcerate, and they don't lend themselves to infection like the rubber ones. Tube ones only are the ones which have to remove every night. You cannot sleep with them in the night because they are associated with malodorous discharge, and one case of RBF has reported it.
Okay, so
But
otherwise, how
they are
frequently?
3 months. 3 months.
3 months.
Yeah, same. I was asking Dr. Geeta how frequently we should call the patient for change of the pessary. Because suppose she's unable to change herself, or wash herself.
3 months.
And put
3
inside.
months. But initially you have to call her weekly to see whether for any malodorous discharge. Basically take her history. If she's happy or not happy, if she's obstructed defecation, if she's gone into retention urine, then you have to change the size. The initial 2-3 weeks will be required for fitting. I think Dr. Rebecca will tell us more. I didn't want to talk too much on that because Rebecca will be talking more about the details of that. But moti baat here that you have to initially train her. First of all, choose your patient. It has to be a compliant, intelligent patient who is willing to come for follow-up. Otherwise, once it's done, 3 monthly change.
In UK, it used to be 6 months. Like we used to change every 6 months, but initially after it settled down, once he was happy with the size and all, and those patients were very intelligent. Actually, they would wash it every day. In the night, they would take it out and put it daily.
Dr. Geeta, suppose there is a discharge.
Hello?
Then should we remove for a few days and give a treatment and reinsert later on?
Yes.
Or pessary should be in the place and we can give the oral treatment. Suppose she's having discharge.
You can remove the pessary,
Pardon?
see if there's an erosion, see if there's a cervical carcinoma. Of course, you would have screened her obviously before putting a pessary. You don't put a pessary without a pap smear and all. But just evaluate the whole vaginal wall for any malodorous discharge, ulcer, erosion. And then, you could put an estrogen cream or an antibiotic cream, depending if it's an atrophic old lady, probably an estrogen cream will be better. But if it's a young lady and there is an ulcer with a slough at the ulcer margin, then she needs antibiotic cream.
Okay.
And then
Sometimes the size may have to be changed. Size may be different. That's why it's
that's why it got.
Yeah, I think we are getting late. So probably thank you very much, Dr. Geeta, for excellent lecture. It's really like an encyclopedic lecture on this thing. I will encourage all this thing. I will encourage you to publish it somewhere. I offer my journal for it if you want to send it. So
I'll be honored, sir.
Yeah. Oh yeah, absolutely. So now without a delay actually, and I congratulate Dr. Geeta for organizing such a lovely program, and that also on such an appropriate topic. I mean, all of us jump to do surgery. What is important as you actually, mature in age, and you feel that, when not to do surgery probably is more important than doing surgery. So
Yes,
that's why this
absolutely.
seminar she has kept it. So now I have great pleasure in introducing Dr. Rebecca Das. She's a pelvic floor physiotherapist, and she has got her own clinic, My Physio, in GK2. And she's also associated with the University of South Australia in a professional certificate course for conservative management of pelvic organ prolapse. So we need to actually highlight that these things are lacking in India, like that, I was in like UK last 1.5 years back, just before COVID, with the King's College, and I saw their physiotherapists, how active they were and how they were encouraging even yoga to the patients and doing proper pelvic floor exercises, and just not asking them just to control, contract the pelvic floor muscle. So we need to know it is a great advancement in itself. Actually, it's a subspecialty in itself. So let's hear Dr. Rebecca Das, and she will, illuminate us with pelvic floor physiotherapy for urinary incontinence and pelvic organ prolapse. Dr. Rebecca, for you.
Thank you very much, Dr. Sharma, for your kind introduction, and also for setting the scene a little bit about what is different internationally with pelvic floor physiotherapy. So I'd like to talk a little bit about what we're trying to do to improve the situation in India, and then launch in. I'll just share my screen if I may. I've got some slides. Can everybody see my screen all right?
Yes, ma'am.
Lovely, thank you. So it is my pleasure to be talking to you today about pelvic floor physiotherapy for urinary incontinence and for pelvic organ prolapse. And of course, the conservative management of these conditions, along with bowel problems and pelvic pain, is what pelvic floor physios do. That's our job. But to address the elephant in the room right up the front, if looking for a pelvic floor physio in India feels a bit like looking for a toilet for an overactive bladder patient, as this picture suggests, I can understand that. And there is a problem with lack of training for pelvic floor physios in India at present. Internationally, pelvic floor physiotherapy is a postgraduate training. So in countries where it's trained, it's usually a postgraduate university degree, either a master's or postgraduate certificate training that is required to work in this field. So it's not something that's taught at bachelor level. So it's not the kind of thing that you can just go to the local physio clinic and expect that the physiotherapists there are trained to deliver pelvic floor physiotherapy. So in countries where there is no university training available, then physiotherapists tend to get their training via professional development courses offered privately. So at the moment, there is, as far as I've been able to find, no formalized university training specifically for pelvic floor physiotherapy, though some universities have in their master's programs gynae rotations where some physios are taught these skills. But so recognizing that situation, I hope that there will be better training for pelvic floor physiotherapists in the future. And what I did when I moved here 7 years ago, when I realized that it really wasn't very available, was I decided I'd start to train some people myself, given that I'm not just a pelvic floor clinician myself, but also a university teacher. And I still teach at the University of South Australia on the conservative management of pelvic organ prolapse. That's actually the title of the professional certificate that I teach. So I've been busy taking notes, and thank you, Dr. Geeta, for such a lovely presentation on pessary use. But I took some notes of things that I could perhaps add to when I get to that part of the presentation. And at the end, if anyone's interested, I do have a list of pelvic floor physios that have been involved in the training that I've done. So if you want to know who's available near you, you can let me know and I can send you a list of names, and many of them have joined us today. So lots of my colleagues are here on the webinar too. So pelvic floor physiotherapy for urinary incontinence and for prolapse, I think we're very lucky in this field of pelvic floor dysfunction that every 4 years an international committee surveys all of the new literature on these topics and then summarizes it and comes up with clinical recommendations. So this is, of course, the International Consultation on Incontinence book, and we're due for the next one to be released, I think, at this year's ICS meeting. So much of what I've included in today's presentation comes from this, but also from more recent research that's not yet been included in this, but hopefully will be in the next version of it. And so in this book, they summarize with flowcharts of how to address these various pelvic floor dysfunctions. And this is their flowchart for the initial management of urinary incontinence in women, which is of course very general. It doesn't give you the intricate detail of what to do, but it gives a good overview. And of course, in the blue box for clinical assessment there, you can see that in urinary incontinence, there are some things that must be screened each time, such as a test for urinary tract infection, and testing for post-void residual, for example. So when we talk about pelvic floor physiotherapy and conservative management of incontinence and prolapse, we always work with our medical colleagues as part of a team to help these patients. So we don't order urinalyses. We might say, you need to go off to your gynae and you need to make sure that you've had these tests done. And then we start our treatment with pelvic floor muscle training. So you can see in the management section in yellow at the bottom there, lifestyle interventions, pelvic floor muscle training, bladder training, and then drugs. So again, of course, physiotherapists are not involved in the prescription of drugs, but we can do the rest of that. That's what we're trained to do. And then if those things fail, then you may need to add on other adjunct therapies such as electrical stimulation or vaginal devices. They say EG cones here. I think you should put EG pessaries. I don't particularly think cones are particularly useful. But let's have a look now at some of the detail behind this idea of lifestyle interventions and pelvic floor muscle training for urinary incontinence. This is the detail of what's included in the evidence summary. So when it comes to lifestyle advice, weight loss has level 1 grade A evidence for effectiveness. So if you do nothing else, if your patient is obese, at least opening the conversation about if they're willing to consider strategies to try to lose weight. Obviously, it's a difficult conversation and many women have tried and have failed. And so they need good support from their health professional to understand how to go about losing weight. 5% of initial body weight loss is what's required to have a good relief from urinary incontinence. So that's often a really achievable target. Moderate physical activity appears to decrease urinary incontinence, whereas strenuous physical activity may actually increase it. And why that is still not understood and is a matter of very rapidly growing research. I think if you have a look there's quite a few recent papers debating this concept of is exercise good or bad for the pelvic floor. In general, we'd say good, but some sports are associated with high levels of urinary incontinence, probably because the pelvic floor muscles can't keep up with the extra demands of those sports. Smoking cessation has level 3 grade C evidence, and then dietary factors, and particularly too much fluid. So they're the bladder diary, which is an essential part, obviously, of managing patients with urinary incontinence is so useful. Many people can be helped simply by being counselled on what they're drinking, when they're drinking, and how much they're drinking. So that's briefly lifestyle advice that has evidence behind it. A lot of other things that we talk to patients about haven't been studied, so we don't have evidence to back them up. In terms of pelvic floor muscle training, thank you very much, Dr. Medirata, for at least flagging at the start, and Dr. Sharma as well, that it needs to be done well. It's not just about telling a patient, squeeze your pelvic floor a few times a day. And this is what the evidence tells us about what's necessary in pelvic floor muscle training for it to be effective. So supervised pelvic floor muscle training should be offered, and that's supervised with a qualified practitioner, such as a pelvic floor physiotherapist. And if you look at the content of pelvic floor muscle training programs in the literature that demonstrates its effectiveness, it's always based on a vaginal examination of that woman's ability to correctly contract her pelvic floor. And we'll talk a little bit more about that in a moment, because a woman's ability is paramount to her exercises. And also there's many different things that can be wrong with the pelvic floor. They're not just always just weak. So identifying the dysfunction to begin with is really necessary. And then clinicians should offer and provide the most intensive health professional-led program that's possible within service constraints. And so Dr. Sharma, you mentioned working in the UK, and they have massive waiting lists for care in all sorts of realms, and particularly gynae. And one of the things that has been demonstrated is that if patients are offered pelvic floor muscle training and it's properly supervised, they can get off that list because many of them will get better. And so one of my colleagues in Australia, her PhD, looked at how many sessions are required, and on average 5. And a patient with stress urinary incontinence was cured. So that's not many sessions. But in the literature, you'll see mostly once a week for the first part of a 3-month program, and then once every 2 weeks for the second part of a 6-month program. So patients need to be willing to exercise for 3 to 6 months to see benefit. And that's where the point was made so well at the start by Dr. Ranjana Sharma, that we need committed patients and committed providers. So patients shouldn't come to their pelvic floor physio thinking that we have a magic wand that we can wave. We're going to teach them exercises and they need to be committed to doing them. And so that's part of our education for our patients. Now, the next point, I know that Dr. Karishma is going to be speaking about biofeedback, and patient selection is essential in knowing whether it's going to be useful, because the evidence so far suggests that there's no point adding electrical stimulation or biofeedback assisted pelvic floor muscle training over and above just pelvic floor muscle training. But I think that's because the majority of women can be taught how to do their voluntary exercises on their own, just with a clinician's practiced fingers, giving them feedback about whether what they're doing is correct, so that a patient is then relying on their own kinesthetic sense to tell them whether they're doing their exercises properly, and they're using their voluntary effort, because there is a large difference between an electrically stimulated muscle contraction and a voluntary muscle contraction, with the voluntary muscle contraction obviously being far superior. Biofeedback can be wonderful if a patient already has a reasonable idea of what they're meant to be doing, and it can be an absolute disaster if the patient doesn't already have a reasonable idea of what they're meant to be doing. And those of you who get the chance, if you've got either EMG or pressure biofeedback, have a go and see how easy it is to cheat. If you, with EMG biofeedback, do a nice strong contraction of your hip external rotators, not your pelvic floor, you'll get a lovely reading on your EMG biofeedback. And similarly with pressure biofeedback, you can get a very good reading by squeezing your abdominal muscles. So patients already need to understand what they're trying to do and have feedback from their therapist on whether they're doing it well before we add in things like biofeedback and eStim to help. But I won't say any more about that because I know Dr. Krishna will be talking about it, but I'm happy to take questions at the end if anyone's curious about that. For stress urinary incontinence, these guidelines tell us that both pelvic floor muscle training and continence pessary are effective in first-line therapy. But as Dr. Medirata said, and I quite agree, pelvic floor muscle training is likely to need to be the baseline, and then you can add a continence pessary on top. And for many women, they might be doing the pelvic floor muscle training and then doing really well, but it's the high-end exercise that they continue to leak when they're doing that. And so that's when they might wear. And this is an example of the Contiform that Dr. Nadirata mentioned. So it's a squishy pessary that's long at the back. So that long piece goes up the back vaginal wall and this short piece sits behind the urethra. Unfortunately not available in India. So when I have patients who need them, I need to bring them back in my suitcase from Australia, which is a bit of a nuisance. But hopefully if there's more urogynes and gynes in India demanding access to good quality pessaries, hopefully the supply of these products will get better, because it is a bit of a problem at the moment getting access to those good quality, nice soft pessaries. So then in those cases where pelvic floor muscle training has done a decent job and they're getting better, but they might still leak when they're doing their runs or their star jumps or whatever it is that they want to do for their general fitness, then maybe they just put the pessary in while they exercise and then they take it out for the rest of the time. So that's another model of using pessary along with pelvic floor muscle training. The guidelines also tell us that for mixed urinary incontinence and urgency urinary incontinence, pelvic floor muscle training and bladder training can both be effective. That's a whole nother lecture in itself, and actually it's my pet topic. I did my PhD on urgency. So pelvic floor muscle training in urgent patients is quite different in its detail to pelvic floor muscle training for stress urinary incontinence, but I won't go into that right now. And of course, when there's vaginal atrophy present, combining with intravaginal estrogen can be really useful. So that there's good evidence for that as well. And I think that is almost like a magic trick. When a woman has dry mucosa, it's a bit like she might be squeezing her pelvic floor muscles quite well, but the sides of that urethra don't stick together because the tissues are dry, and so she still leaks. So it can be a really useful thing to add on. So when we think about interprofessional management of urinary incontinence, it's not an either or. It's not see your pelvic floor physio or your gynecologist. It's see us both, because we work together. It's really necessary. So the model that I was used to back home in Australia and that I still follow here is that my patients need to see a urologist, urogynecologist or gynecologist to confirm the diagnosis. Exclude alternative pathologies, because that's not within the remit of a pelvic floor physiotherapist. And then these specialists will offer surgery where either that approach is preferred by the patient or where the first-line therapy has failed. But I think the issue that I see a lot is that first-line therapy is not done well enough first, and I'd really love to see more effort put into patients succeeding with first-line therapy. And then, of course, the medical prescription, because physios are not qualified to prescribe medicine. Whereas what the pelvic floor physiotherapists will do in conjunction with you is assess those pelvic floor muscles in detail and do a bladder diary to inform the lifestyle management. So we refer back to the medical practitioner if the appropriate assessment hasn't been done. And after assessing the pelvic floor, we'll prescribe appropriate pelvic floor muscle exercises. And as I mentioned earlier, it's not a quick fix. We need 3 to 6 months of patient effort. And we supervise that training at intervals necessary for that patient. In patients who have trouble learning, we might see them quite regularly in the first few weeks. Once they've learned what to do, if they're a motivated person and I know they'll do their exercises, I don't ask them to keep coming in. They do their exercises, they come in when it's time to upgrade the exercises to something more difficult. And that leads into the next point, that for pelvic floor muscle training to be effective, you need progressive overload. And so that means the exercises need to be changed regularly enough to challenge the muscles so that you actually achieve hypertrophy. And that's difficult. So the exercises must be progressed along the way and hopefully integrated into that patient's general fitness program. We like our patients to be doing other exercise too. And you can incorporate the pelvic floor muscle training into the other forms of strength training that they might be doing. Then, of course, there's the lifestyle management, the fluid advice, the weight management, and with Prolapse, a few other things like management of intra-abdominal pressure, which I'll talk to later. So pelvic floor muscle training, it's not just go home, do Kegels. An accurate assessment is very necessary. So pelvic floor muscles can have either high or low resting tone. I mean, if it's high resting tone, that needs to be addressed before you launch into a strength training program, or you can actually make them worse. They may be weak. They may be high tone and weak, which is a very common presentation. They might actually just be very poorly coordinated or isolated, and I very commonly see women who can do a good contraction only if they hold their breath. And of course, that is useless in learning to control incontinence. And I see other women who can only contract their pelvic floor along with a strong abdominal muscle contraction, and that again is very unhelpful. So sometimes we're having to undo motor patterns that are unhelpful. There can be pelvic floor muscles that are very slow to relax after they've contracted, and this can lead to voiding difficulty, but also can lead to pelvic pain in patients who end up with painful muscles. They can be very sluggish or slow to contract, so they might take a long time, get a really decent contraction, but it's too slow to catch a cough or a sneeze. So then we might need to do speed training. And the muscles might not be moving in all three directions they're meant to move in. So of course, the pelvic floor muscle is meant to elevate, move posterior to anterior, and also squeeze from side to side. And some patients have one of those things happening much more predominantly than the others. And so we might need to train their technique as well. So we individualize our exercise prescription to what the patient is able to do. And chiefly, they must be aware of both their contraction and their relaxation to be able to manage an exercise program at home. We have to determine how long they can hold for and progress that in increments. We need to work out if they need to practice their isolation. How many repetitions should we be including at the start, and how do we progress that? Do they need a focus on strength, endurance, speed, or function, or all of those things? So that's what we work out as we prescribe exercises. This is a list of the type of things that I tell patients that pelvic floor muscle training can do to them. And I like to point out that we actually have evidence for all of these things. And I've listed some of the references if you're interested. And I have reference lists at the end of my presentation here, which I'm happy to share with people if anyone wants to read the literature. But if we strengthen pelvic floor muscles, we're reducing age-related muscle loss. So now I am thinking about these postmenopausal women with POP as well. And what happens is the pelvic floor muscles end up in a higher, slightly higher position in the pelvis, providing more support for the bladder neck. And we have seen via MRI investigation an increase in the size of the external urethral sphincter. They have improved reaction time of the pelvic floor muscles, so they react better to cough, sneeze, laugh. They learn better bladder control, which helps maintain the compliance of the bladder. Obviously, if women are running to the toilet every hour, their bladder loses that ability to fill. They have a better sense of how to hold on and better confidence that they can hold on. And interestingly, they also get improved blood flow to the vulva, and that can improve dryness symptoms as well as urinary symptoms. And then some of the types of exercises that we do aim at improving the flexibility of the vaginal opening and the ability of the muscles to relax, which can help with painful intercourse. Lastly, and this is where it's really important for pelvic organ prolapse, learning to manage raises of intra-abdominal pressure with closure of the levator hiatus. So the woman needs to understand that she is actually closing her levator hiatus, and that's the role of her exercise, is to close underneath and lift. And so then we train them to do that along with activities that rise intra-abdominal pressure. So this is the example of the treatment algorithm in the ICI book for prolapse. And again, very basic, it doesn't include the detail, but we see the clinical assessment requiring symptom assessment, and then things like the post-void residual urinalysis if necessary, and a physical examination to confirm prolapse. And again, if a patient comes first to me as a pelvic floor physio saying, I've got a prolapse and they haven't seen their gynae, I would send them immediately back to their gynae to make sure that a proper examination is done and that prolapse is confirmed as the diagnosis and that it's not some other kind of pelvic mass or pathology. That's an important part of the initial screen. And so then management, of course, is pelvic floor muscle training and pessary to be tried prior to surgery. It's the general recommendation. And this is an example, again, of another pathway that was published in Australia, actually, by the Australian Commission on Safety and Quality in Healthcare, after what you may have heard about with the class action against the producers of mesh products, when there were so many women who had rather severe side effects with having mesh used for prolapse repair. And so mesh has been banned in Australia and a few other countries, and this was the algorithm provided to give information to patients about their options for care when they have a prolapse. And again, you can see in first line management, observation only, lifestyle changes, weight reduction, avoiding chronic constipation, heavy lifting, chronic cough. And again, as physios, we delve into that too in terms of patients with lung problems, teaching them ways to manage that so that they're not coughing all the time, how to sit on a toilet and push without straining in such a way that they make their prolapse worse, etc. So we can help with that kind of first line management as well. And then supervised pelvic floor muscle training, and then pelvic organ support, pessaries, and local estrogen. And then if those things don't work, on for other surgical options. So physios in pelvic organ prolapse, how can we help you with your patients? Well, we can support them in maintaining an active lifestyle. One of the saddest things is when women stop exercising and stop going out because of their prolapse, and they end up with a very restricted lifestyle. So we can support them to do their pelvic floor muscle training and or use a pessary so that they can maintain an active lifestyle. We teach them how to manage those rises in intra-abdominal pressure. When they're lifting, when they're pushing, when they're pulling, when they're doing any of those things, how to manage that by integrating their pelvic floor muscle training and combining that with their general exercise. We help manage their bowel problems. We spend a lot of time talking to people about the nature of their poo and how to evacuate it properly. And of course, managing other concomitant pelvic floor muscle dysfunction symptoms such as urinary incontinence or pelvic pain. And as I mentioned, promoting management of cough, etc. So in terms of conservative management of prolapse and the evidence, Dr. Medirata already went through evidence on pessaries, and I'll get to a few others that I can add to that in a moment. But again, in this International Consultation on Incontinence book, it points out there hasn't been a lot of research into lifestyle interventions for prolapse. So it's kind of like accepted wisdom that we advise them various things like not spending too long on your feet. If you have been on your feet for hours, go lie down for 15 minutes, do some bridging. So things like that are part of accepted wisdom don't actually have a lot of research support because the research hasn't been done. But in terms of pelvic floor muscle training for POP, and this is properly supervised pelvic floor muscle training. It's not go home and just do some Kegels. These were women who were assessed, given an individualized program, and did their exercises for 6 months. So these are the studies that have looked at the effectiveness of that. So the two studies by Hagen and colleagues were published in the Lancet some years ago and showed that pelvic symptoms as measured by the POP-SS questionnaire. And interestingly, the same group in 2019 published at the ICS meeting an abstract that looked at 10-year follow-up of the women who had joined that first study on POP and discovered that the women who had been in the pelvic floor muscle training group had decreased hospitalization for pelvic floor dysfunctions in the 10 years following up. So it seems to be worth it long term as well. And studies by the Scandinavian group, Bracken and colleagues, first of all showed that pelvic floor function is independently associated with pelvic organ prolapse. So having low vaginal resting pressure and weak pelvic floor muscles was associated with POP in the first place. And that if you do training, the things that changed after 6 months of training was increase in the muscle thickness, decrease in the muscle length, and decrease in the levator hiatus area on Valsalva, and the bladder was in a more elevated position. So those were the changes that occurred with training. So physios and pessaries, how does this work? We again work as part of a team looking after our patient. So there are two models essentially of pessary management. One is what, as physios, we call the gynecology model, and the other is the self-management model, and both of them involve the gynecologist. The second one can involve a physio as well. So the idea is that some of the literature talks about patients being fitted with a pessary by their gynae, and then the gynae chooses how often they will review that patient, take the pessary out, use a speculum to check those pessary walls, make sure it's okay, put the pessary back in or give them a new one if they need it. And it's just managed solely by the gynecologist with the patient. And interestingly, what does the literature say about how often to change it? So Dr. Medirata mentioned 2 to 3 months in her clinical practice. Dr. Sharma just mentioned that back in the UK, they tended to do it 6 monthly. Some very recent studies were investigating, can you leave it in for 2 years at a time and not get problems? And they discovered that they had high rates of success. That makes me feel very nervous knowing what some of the complications are. But just to let you know, there's no definitive guideline on how long to leave it in. It's left up to the gynecologist to choose what they think is appropriate for their patient. So that second model is this called the self-management model. And so that's where the patient is taught how to put their pessary in, how to take the pessary out. And in cases of the Gellhorn and the Cube, they're asked to take it out overnight once a week, wash it thoroughly in soap and water, so they give it a good old scrub, leave it in a nice clean place overnight, and then put it in again the next morning. And then again, they need, under their gynae's instruction, to go see the gynecologist at whatever interval the gynecologist decides. So that's not decided by the physio, that's decided by the gynecologist, because the gynecologist will do the speculum check again to make sure that the patient's not developing erosions. They'll do a swab to make sure they're not developing infections, etc. But the physiotherapist's role is to teach the patient how to manage the pessary. So that's where the joint model has emerged overseas, that because physios are already involved in teaching the pelvic floor muscle training and the lifestyle management, that we seemed to be in a good place to be the ones to actually teach the patient how to use their pessary. So that's what we teach in Australia. And that's
Rebecca,
what I'm...
Dr. Rebecca,
Yeah.
sorry for the intervention. Actually, we have limited time span,
Yes.
so cut short your...
Sure, what would you like me to focus on?
Just please be a little faster. No?
Speed it up a bit? Sure. All right. All right. So that's the model. Anyone who wants to ask more questions about how that works in practice can let me know at the end. So pessaries, are they safe? Do they work? Perhaps I'll skip over this a little bit because Dr. Medirata also already spoke about some of the evidence that's available. All of these references I have on my slides at the end. So if you'd like to have a look at those, you can. The main issue is randomized controlled trials haven't been possible. They're ethically questionable to compare pessary with surgery. So most of the trials are single arm, looking at whether a pessary changes symptoms, and they seem to be quite effective. Complications are rare but potentially serious. So as Dr. Medirata mentioned, they can actually erode right through the vaginal wall into the bladder or the rectum. And I've heard stories of surgeons having to extricate pessaries out of bladders. So they should not be neglected. And that's where the regularity of when they're checked should be foremost in terms of how compliant a patient is going to be. But complications have been demonstrated to be less severe compared with surgery and a little bit rarer compared with surgery. Somebody asked earlier about pessaries after surgery, and you certainly can use them after surgery, but that's one of the things that has been shown to predict failure, is that they're more difficult to fit after reconstructive surgery. So let me just whiz through my last slides here. Predicting fitting success, how many trials might you need, which one to choose? I think Dr. Medirata has already spoken about, and does the stage of POP matter? So a good fit is a pessary that corrects the POP, that you can fit a finger around the side so it's not really tightly wedged against the vaginal walls, but that the patient cannot feel it once it's in situ, and they can empty their bladder and bowel properly and it doesn't fall out on provocation. Make sure you put them through all the provocation you can while they're in clinic with you to be as sure as you can that it won't fall out. Fitting success has been defined as pessary fitting failure, the inability to achieve a comfortable fit with up to 3 trials in 3 weeks. So trial well while they're in the clinic. If the first one fails, consider a different size or a different type. Predictors of failure, according to a systematic review in 2020, so high BMI, previous reconstructive surgery, and advanced POP. But it can work in advanced POP, so try. And let me show you in a little while some studies that have involved grade 3 POP and pessary still work. So approximately 30 to 40% of patients will require up to 3 trials, and sometimes even more. I've heard stories of 5 or 6 pessaries being tried. And that's from these studies here that indicate that many trials are required. There are clinical practice guidelines very recently published from the UK that are nice to look at. If you've not done a lot of this, these guidelines are very well worth looking at, and they actually provide advice on training, how to get training to fit pessaries. They suggest a ring first because it's the easiest for a patient to self-manage, and you can engage in sexual intercourse with a ring in situ. Gellerhorn if the total vaginal length is decreased, particularly after surgery. And Nemeth and colleagues actually studied the cube and found it had, as a cube, quite a low complication rate. But I would agree with Dr. Medirata. I've heard stories about severe complications if they're not well managed. So this is an example of the UK guideline. So if you'd like to go look that up, you'll find it quite easily on Google. And it has these lovely flow charts on how you might go about choosing what type of pessary you'd like to use. And then finally, does the stage matter? I've listed some quite recent studies in yellow at the end there, where all of or most of the patients had grade 3 POP. And I have successfully managed some quite advanced prolapses. It's taken quite a lot of trial and error, and ring stacking, for example. So Dr. Medirata showed 2 cubes in place, trialing 2 rings, big one first, little one next, or the other way around. So often you can get success with a little bit of imagination if first trial doesn't work. So it's worth a try, and particularly considering if you've done surgery first, you might be less likely to be able to fit a pessary later. So it might be better to do it the other way around, try a pessary first and surgery second if it doesn't work. So that's the guideline. Just to show you the screenshot with the link at the top, an example of their training requirements logbook that they have inside, where you can have a look at what skills you need to learn to fit a pessary. I was then going to talk about access to pessaries, but I think we can leave that alone and talk about that if necessary. So if you want to know where your local pelvic floor physiotherapist is, there's physios, my colleagues, that I can recommend in all of these cities. So let me know if you'd like their contact details. And that's enough from me. So I'd like to hand back to Dr. Sharma. Thank you.
Oh, yeah,
Thank you.
Thank you. Dr.
Yes, sir.
Mansi,
Yes,
you
sir.
can.
Please, sir. Sir, please.
Yeah. So just, thank you very much, Dr. Rebecca, for your excellent presentation. And you have beautifully highlighted the role of conservative treatment, especially pelvic floor exercises. And you have beautifully highlighted that this is not just saying that do Kegels, that's not enough. And many of the time, with all apologies to my colleagues, I mean, we don't have enough time. We just say, okay, just, contract your pelvic muscle, contract your abdominal muscle. So that will not work. And as he has rightly said, there is grade 1, level 1 evidence of Cochrane that supervised pelvic floor muscle training is the first line of treatment and must be offered to every single patient. So thank you very much, and I will request Madam Mansukani as well as Dr. Harsha to give their comments.
Yeah, thank you, Dr. J.V. Sharma. Yeah, I would like to say thank to Dr. Rebecca for her excellent lecture, and she covered all the points regarding the physiotherapy, role of the physiotherapy, especially in the POP and urinary incontinence. And actually, there should be a team of the urogynecologists along with the physiotherapist so that we can deliver the good services to the patient and they can even manage without the surgery. And nowadays, actually, most of the patients, they want non-surgical options. So we have to give them these all options and let them decide what they want exactly for themselves. So definitely there is a role of the team approach, and there is a role of the physiotherapy in the management of the POP and urinary incontinence. So thank you, Dr. Rebecca, because of the lack of the time, we have to move ahead. So I have to introduce the next speaker, Dr. Karishma Thariani. She is senior consultant at the Center for Urogynecology and Pelvic Health. Dr. Karishma she has an area of interest, especially in the urogynecology and pelvic reconstructive surgery and menopause. Dr. Karishma is going to speak on pelvic floor physiotherapy using biofeedback, a conservative modality for managing POP and urinary incontinence. So without wasting time, I would like to request Dr. Karishma Thariani to go ahead with her lecture.
Thank you so much, ma'am. A very good afternoon to everybody. Before I start the lecture, I would like to thank the organizers for giving me this opportunity and like to congratulate.
Your volume is low, Dr. Karishma.
Am I audible now, ma'am?
Better, yeah.
So before I begin, I would like to congratulate Dr. Geeta and Dr. Rebecca for their extraordinary and exhaustive lectures on pessaries and pelvic floor physiotherapy. So they have done most of the job for me. I'll just share my slides. Just a second. Are my slides visible? Are my slides visible?
Yes, ma'am.
Yes,
They're visible,
Karishma.
ma'am. You can
Yes,
continue.
Karishma, go on.
Yeah, so the topic that I shall be talking on today is pelvic floor physiotherapy using biofeedback as a conservative management modality for urinary incontinence and pelvic organ prolapse. So a lot of this is basically a continuation of what Rebecca has already told us. So I would like to begin my talk with a little overview of what the pelvic floor consists of. So this is for the sake of the PGs who are there. The pelvic floor, the most important muscle in the pelvic floor, as we all know, is the levator ani. It has three components: pubovisceralis, puborectalis, iliococcygeus, gets its nerve supply from the S2, S4 segments. And this muscle consists of two types of fibers: slow twitch and fast twitch fibers. Out of these, 70% are slow twitch fibers. Why is this important? What does levator ani does, or the pelvic floor does for us? At rest, the levator acts to keep the urogenital hiatus closed in response to gravity or increased intra-abdominal pressure. This can clearly be seen with the boat in the dry duct analogy, where this water is the pelvic floor and the organs are the ship. These are the connective tissue and the ligaments. If there is no water, then there will be excessive strain on the endopelvic connective tissue and the ligaments, leading to pelvic floor dysfunction. At the time of activity, more fibers are recruited to maintain the hiatal closure by the levator. So during a normal pelvic floor muscle contraction, there is urethral closure, hence preventing urinary leakage, forward and upward movement of the pelvic floor muscles, and resistance to downward movements of the organs. That is, this contraction of the pelvic floor muscle helps in reducing both urinary incontinence and pelvic organ prolapse. Why pelvic floor muscle training? Around 80 years back, Sir Arnold Kegel elucidated for the first time that with adequate pelvic floor muscle training, a woman may learn to maintain her perineum, bladder, and uterus in a higher position and reduce the slack in the supportive muscles and make the vagina longer and tighter. Obviously, 80 years down the line, we have better evidence which basically supports what he says. Intensive strength training may build up structure support of the pelvis by elevating the levator plate to a permanently higher location, enhance hypertrophy and stiffness of the pelvic floor muscles, reduce muscle length, and help in the constriction of levator hiatus. That is how pelvic floor muscle training works. Now, before we go to pelvic floor muscle training, it is very, very important for us to understand that there is no replacement for a complete and thorough clinical examination of the patient. Every time you do a gynecological examination of a patient, you have to assess her pelvic floor muscles. This can be done by various methods. The most common is digital palpation. You feel for the patient's muscle, you assess the patient's ability to contract and relax. Measure the pelvic floor muscle strength via maximal occlusive and lifting force, which is known as maximum voluntary contraction. Ability to sustain a contraction or endurance when you ask her to hold on to the contraction. And last, to perform a number of repeated contractions. That also comes under endurance. Coordination with the lower abdominal muscles. Like Rebecca said, a lot of patients use their lower abdominal muscles while contracting their pelvic floor muscles. That obviously is of no help. Symmetry of the right and left pelvic floor muscle contractions. Again, along with the pelvic floor muscle strength, contraction, endurance, we also need to look at other factors in the pelvis. Is there any scarring in the muscles because of old episiotomy wounds or any other pelvic surgery which has been done in the past? Adhesions in the pelvis, presence of pain in the muscle, or what we in medical words call the trigger points, or any major pelvic floor muscle injuries. All these need to be clinically assessed. More than 25 scales exist in literature for a measurement of the pelvic muscle tone or strength. The most commonly that we use is the modified Oxford grading. It basically measures the squeeze and lift of the pelvic floor. So this is a very old video. If you see here, the examiner has two fingers inside and the thumb outside, and she's digitally palpating the patient's pelvic floor muscles, looking for the bulk of the muscle, any scarring, trigger points, and then she asks the patient to contract. And you can see the perineum going up and then coming down when the patient relaxes. So it is both the squeeze and the lift, what Rebecca explained as the anterior-posterior contraction and the right to left contraction of the pelvic floor, which needs to be assessed while you're palpating the pelvic floor muscles. These are then divided into 6 grades from 0 to 5. There are other mechanical methods of looking for the pelvic floor strength. There are many, there are needle electrodes, but the one that is again commonly used is the manometry. You have a vaginal probe and you have a screen, a digital screen, and you put the vaginal or the rectal probe in the rectum, and then you ask the patient to squeeze. When the patient squeezes, then the muscle contraction comes, the strength of the contraction comes as a reading. If it is attached to a laptop or a bigger screen, then you see contractions like this, which we call as maximum voluntary contraction. We take at least 3 contractions and then calculate the average of those. Based on your assessment, you need to divide the pelvic floor muscles into 3 types. Normal pelvic floor muscle, which is able to contract and relax on command and in response to increased intra-abdominal pressure as appropriate. Underactive pelvic floor muscles, which are unable to contract sufficiently or when needed. That is muscles which are weak, the kind of muscles we find in our stress urinary incontinence or prolapse patients usually. Overactive pelvic floor muscles. What are overactive pelvic floor muscles? These are muscles which are unable to relax and may contract during functions such as defecation and micturition. Like there are women who are unable to relax their pelvic floor completely, leading to voiding dysfunction, constipation, sexual issues like vaginismus, etc. So the initial assessment of the patient really plays a very important role in classifying the patient into either of these categories. These categories also help us in knowing what are the indications where the pelvic floor muscle therapy helps. First and the most important indication is that the patient should be desirous of conservative management. Others are patient with incontinence. We've already gone through this through Rebecca and Dr. Geeta. Patients with incontinence, both stress and urgency. Patients with pelvic floor dyssynergy are leading to voiding dysfunction or constipation. Patients who have weak or hypertonic pelvic floor, such as patients with pelvic organ prolapse. Patients of sexual dysfunction, such as vaginismus, or women with chronic pelvic pain or hypertonic pelvic floor. Once the indication is clear, now in stress urinary incontinence, there could be three scenarios. Imagine a woman who has stress incontinence and she has muscles which are normally innervated and sufficiently attached to endopelvic fascia. In such a patient, you need to only train her when and how to use her pelvic floor muscles, and that will be effective therapy for her. Imagine a second woman who also has strong muscles, but these muscles do not get activated at the time of cough and hence cannot prevent incontinence. Teaching such a patient of not just the timings when to contract her muscle, but also to increase her awareness of her pelvic floor muscles becomes a challenge. In such women, there may be a role of biofeedback therapy. There is a third category of women in which the pelvic floor muscles are denervated because of substantial nerve injury, previous surgery, or any other maybe radiotherapy, chemotherapy given in the past. In such patients, strength training and measures to stimulate the rest of the muscles through electrical stimulation may play a role. Now, when we talk of stress urinary incontinence, the two major techniques that we teach the patient are bracing or performing the NAC and the regular strength training. NAC is when a woman learns to consciously contract before and during the increase in abdominal pressure and continues to perform such contractions as a behavior modification. If you look at the graph on the right side, you will see that the urinary leakage comes down in women who do NAC, both with medium and strong cough. Regular strength training basically help in increasing the stiffness and structural support of the pelvic floor over time of training. Urgency urinary incontinence. Rebecca has very wonderfully explained that initially the question that most people would ask me was, how does the pelvic floor muscle therapy helps in urgency incontinence? Or does it even help? Does it even have a role? This has been clarified by Rebecca in her lecture. Now, how does pelvic floor muscle therapy help in patients of urgency incontinence? There are various theories. Intentional contraction of the pelvic floor muscle during urgency and holding of the contraction until the urge to void disappears can stop urgency and prevent incontinence. Strength training of the pelvic floor muscles makes permanent morphological changes to the pelvic floor, which may stabilize neurogenic activity and urethral pressure. It also helps in increasing the maximum urethral closure pressure. There is a theory which says a strong contraction of the pelvic floor muscles can inhibit the detrusor contractions. So this is what happens when the urge wave comes. It comes, it grows, peaks, subsides, and then stops. The usual response of a patient to urge wave is to immediately leave her work, get up and run the moment the urge wave is growing, because she is scared that she might leak. To such patients, we teach them to be still when the urge wave comes, exercise, distract herself, wait for the urge wave to wane off, and then walk to the bathroom. This really helps in curbing down the urgency incontinence and what we call bladder training in these patients. Next is pelvic organ prolapse. Yes, again, the evidence has been shared in the previous lectures. It works in a similar manner as in stress urinary incontinence, both bracing and strength exercises. The question is, does it really work? Because most of us, when we counsel the patients, we say that the best treatment for pelvic organ prolapse is surgery. Yes, to some extent it is true, but pelvic floor muscle therapy also works. So in patients who are not bothered by their pelvic organ prolapse is a condition where the patient should ask you for surgery, not the doctor recommending the surgery to the patient. So if the bother scores are less, in patients ranging from stage 1 to stage 3 prolapse, pelvic floor muscle therapy should be tried as the first line. There have been over 10 RCTs. Again, the names of those various RCTs have been shared in the previous lecture, which have showed that pelvic floor muscle therapy, when done properly over a period of 3 to 6 months in a supervised individual manner, helps in typically lifting the stage by 1, improves symptoms, improves comorbidities, and most of all, is free of complications and side effects. It also brings about morphological changes in the muscle, increases the muscle thickness by 1.9 millimeters, reduces the muscle length by 6.1 millimeters, reduces hiatal area, raises the bladder neck and rectal ampulla, therefore reducing pelvic organ prolapse. So what do we do in pelvic floor muscle therapy? Like I said, we do a combination of bracing and regular strength training. I've already explained what are bracing. Bracing is quick squeeze and lift before any increase in abdominal pressure. Strength training is done as varied sets or varied number of contractions per day, depending on what the patient can do and what her muscle strength is like. The number of contractions recommended may range from 8 to 12 done 3 times a day to as many as 50 to 100 contractions per day. Duration may vary from 4 seconds to 30 to 40 seconds. Duration of treatment may vary from 6 weeks to 6 months, commonly 3 months. Now, what happens when we do this therapy, when we assess the patients? We realize that more than 30% are not able to contract when first instructed. Only 49% patients are able to increase their urethral pressure during a PFM contraction. 25% strain instead of contract. That is, they basically, if you ask them to do it at home by themselves, by just giving them verbal instructions, they will most likely make their condition worse by doing the exercises. Also, while you're examining the patient or doing or teaching her exercises, watch for lifting of buttocks, thigh activation, breath holding and pushing maneuvers in the patient. So what is the solution for this? Biofeedback, again, as I said, is not a replacement of a therapist or a clinician. It is just a tool to explain the patient better what to contract and how to contract. It is just the transformation of a physiological process into a visual, acoustic, or a sensual information. It is not a replacement of pelvic floor muscle therapy. It is just a device which helps the patient to understand better. And like all machines, it is very easily to be cheated by the biofeedback apparatus. It provides a moment-to-moment information about a biological function, can be achieved through direct palpation, EMG systems, or pressure-based biofeedback. Now, what comprises of a biofeedback apparatus? There's a vaginal or a rectal sensor used to measure electrical activity of the muscle. The information is transmitted to the patient using a visual stimulus in most cases. The patient is made aware of a muscle activity and uses the feedback to become aware of her muscles and recruit them better. It does not help in strengthening her muscle. It just helps her to identify which muscle she needs to use. Biofeedback helps to improve pelvic muscle contraction and also helps to hold the contraction for a longer time. The apparatus that we commonly use in our clinic is Uristim. We have also recently started using the Maple device. I'll talk about each one of them subsequently. So if you look at the Uristim here, it has 3 output channels. One is for electrical stimulation, one is for abdominal EMG leads, and one is for the manometry channel. So as I said, like any machine, it is very easy to get fooled by the biofeedback. Like if a patient is using her lower abdominal muscles to contract her vaginal muscles, you will still see the graph going up. So for this, we have the abdominal leads. We place the abdominal leads on the patient's abdomen, and the manometry probe is put into the patient's rectum. And then when she's asked to squeeze, you see a graph something like this. This shows the changes in the vaginal pressure, and this shows the changes in the abdominal leads. Also, biofeedback is, again, like I said, it is not a replacement of a therapist or a clinician. It cannot be done by an untrained person. It has to be done by someone who has an understanding of the pelvic group of muscles, the abdominal muscles, the buttocks, and the thighs. It has to be done by the clinician or the therapist herself, sitting right in front of the patient. So it is an observation on the screen for the patient, and for the clinician or the therapist, it is the observation of the patient as a whole, looking at what she is contracting, how she is contracting, and for how long she is contracting. This is just a tool which helps in better understanding and identification of the right muscle. So here you see when the patient is asked to contract, the vaginal pressures are, the anal pressures are rising, or if you use a vaginal probe, then a vaginal pressures you can see rising. These are the abdominal efforts. So if you see a picture like this, you know that the patient is also using her abdomen. She's squeezing her abdomen to bring about the contraction in her pelvic floor. So this is again a video. You see that the probe is inside and the patient is asked to squeeze for 10 seconds. When she squeezes, the graph goes up. The lower one shows the abdominal. And then she's asked to relax. Relaxation is equally important. Then we practice the knack, in which we ask the patient to squeeze for 2 seconds and then relax. So when she squeezes, you see the probe going up. And then when she relaxes, it comes down back to its original position. So this is a graph pre-treatment and post-treatment of a patient after with biofeedback. You can clearly see the change in both the resting and at the time of contraction. At the time of resting, if you see, there is less variability in the amplitude. The patient is able to relax better. At the time of contraction, you can see a more sustained, less variable contraction. So this is how biofeedback helps you in getting a visual picture of what you would have otherwise done through clinical assessment. Next is electrical stimulation. Again, electrical stimulation is a technique for passive contraction in patients who cannot contract pelvic floor muscles. So one thing I want to convey to everybody is that it is not like a package of biofeedback with electrical stimulation. One size fits everybody. No, it's not like that. You need to choose the right patient for the right tool. And that choice can only be made if you have assessed the patient completely and thoroughly. Electrical stimulation can be administered through vaginal or anal electrodes. I showed the vaginal electrode for electrical stimulation in the previous picture. Two major purposes: motor excitement and analgesic action. It can also be called a lazy man's Kegel. So there are various theories on how electrical stimulation works. It works through bringing about molecular changes in the pelvic floor, through better identification of the muscles, and a lot of different theories are there. So the apparatus that we have offers 6 frequencies: 10, 12.5, 20, 50, 100, and 200. The frequencies are, again, the choice of frequency depends upon the diagnosis of the patient. It is basically when the stimulation comes and when the stimulation stimulates the muscle, the patient feels the contraction. It makes her more aware of a pelvic floor contraction, apart from stimulating the pelvic floor musculature. So for urgency incontinence, the frequency that's normally used is 10 to 12.5, 20 for mixed, a higher frequency for stress incontinence, and even higher for hypertonic pelvic floor to cause sustained relaxation. Now, clinical recommendations for electrical stimulation. Now, it is rightly said that there is very little evidence which supports use of electrical stimulation as the first line modality in all patients, and I've already emphasized that. It has also been emphasized by Rebecca. It has been suggested that electrical stimulation restores continence by strengthening the structural support of the urethra, securing the resting and active closure of the proximal urethra, strengthening the pelvic floor muscles, inhibiting the reflex bladder contractions, and modifying the vascularity of urethral and bladder neck tissues. The parameters are mentioned here for anybody who's interested or has similar apparatus. Electrical stimulation is better than no treatment or placebo, but there is very little evidence in favor of doing electrical stimulation in all patients. So yes, we do not recommend it in all patients, but yes, in patients who have denervation injuries or pelvic floor muscle injuries, in those patients, pelvic floor electrical stimulation does work. The variation in data in the available literature is also because there is so much variation in the different, in the kind of data that is there. There are different protocols which are used, there are different time intervals which are used, different patient populations, due to which there is no standardization or accurate data which is there supporting this modality. Clinical recommendations for electrical stimulation and overactive bladder. If available, it should be applied. Follow up with weekly or more often supervised training. Supervised trainings must be conducted individually. The parameters which we use for electrical stimulation are mentioned here for anybody who's interested. Duration of treatment is usually 3 to 6 months. Clinical recommendations for pelvic floor muscle treatment in pelvic organ prolapse. Watchful waiting is recommended for pelvic organ prolapse stage 1 to 3 if symptom bother is absent or low. Again, watchful waiting is something that we as gynecologists or urogynecologists don't really like to do. Because if a patient comes and we see something, we really feel like taking it off or making the patient better. But there is evidence which show that watchful waiting for as long as 5 years can lead to 40% regression. And only 13% cases showed progression. So 40% I feel is a huge percentage to give conservative treatment like pelvic floor muscle therapy a chance in such patients who are not bothered much by their symptoms. There are convincing results from 8 RCTs that pelvic floor muscle treatment should be first-line treatment for women presenting with symptoms of pelvic organ prolapse. Again, there is very limited data on electrical stimulation and pelvic organ prolapse. A little bit about Maple. Again, Maple is a biofeedback device that we have recently started using. The only difference between Maple and Eurostim is they pretty much work on the same principle, is that Maple gives you a targeted picture. It basically divides the pelvic floor into this grid. So these are the muscles that you see everywhere. It gives you a picture of the entire pelvic floor. It also gives you a reference comparison, a comparison with the reference population. So red means overactivity, and blue means underactivity, and white and gray means very similar to reference. So this helps in giving you a picture. This is more important in patients with hypertonic pelvic floors or in patients with dysfunctional voiding, because it gives you an exact picture that which part of the pelvic floor is hypertonic. And you can also do targeted electrical stimulation with the use of this device, because it tells you you can actually stimulate only in the areas, only to the muscles which are hypertonic and not the entire pelvic floor. Like this is ring stimulation where the entire muscle in the first row is being stimulated. This is a more targeted or a plate stimulation where only these muscles which are affected are being stimulated. Now, once we've talked about the devices, what does the evidence say? Again, evidence has been very thoroughly and nicely compiled by Rebecca. I'll just give you the highlights. That a pelvic floor muscle training versus no treatment in patients of incontinence. Pelvic floor muscle training should be first line in management of women with stress or any other type of urinary incontinence. Role of biofeedback in augmenting pelvic floor muscle training for urinary incontinence. This RCT was concluded by saying that it may provide benefit in addition to pelvic muscle training in women with urinary incontinence. However, further research is needed. What does NICE says? NICE says that offer a trial of supervised pelvic floor muscle training to women for at least 3 months duration as a first line. These are women with urinary incontinence. Pelvic floor muscle training program should comprise of at least 8 contractions performed 3 times a day. It does not support the use of pereniometry or EMG as biofeedback as a routine part of pelvic muscle training. It also does not support the role of electrical stimulation. So I would like to, in the end, summarize by saying that electrical stimulation and biofeedback should be considered in women who cannot actively contract the pelvic floor muscles in order to aid motivation and adherence to therapy. It is not a replacement of pelvic floor muscle therapy or the clinician or the physiotherapist. It is just a device, a tool. Again, there is a summation of the evidence that pelvic floor muscle therapy is level A as first line for stress incontinence, overactive bladder, and prolapse. Thank you.
Thank you, Dr. Karishma, for your excellent lecture, because you covered all the points and you nicely explained what is the role of the biofeedback, because you have to decide what type of the therapy patient needs and what muscles should be stimulated and in which manner. And that will be, I think, what I understood, that will be decided after the biofeedback. So that is a very important thing. And you nicely covered all the points of this and you explained nicely. That is very good. Thank you very much once again. And I would like to request Dr. J.V. Sharma to conclude the session. Dr. Sharma, are you there?
I think he has left.
He has left, Dr. Chandra. Dr. Achla, can you just conclude the lecture session, please?
Sure, definitely. I think I will start from, the last lecture. I think Karishma really needs to be applauded for what she has explained so well and so clearly and crisply. Because this misconception I have seen is there in many people that biofeedback is, you stimulate and the muscles will get better. So that concept has been cleared, and then Rebecca has very nicely told us all about the use of a physiotherapist after a gynecologist has found the problem and taken out the contraindication. Then how, because as a gynecologist or even as a urogynecologist, we cannot spend as much time as required for physiotherapy. because this PFMT is, like Dr. Ranjana said, that doctors' patients and patients' patients, both are required. And for that, lot of time is required. And if you spend that much time, you can really help the patients. For that, a physiotherapist role is very much there. And there has to be a team of, physiotherapists and a urogynecologist to treat a patient conservatively. And Dr. Geeta's lecture, of course, was an encyclopedia about pessaries. And I think everybody must have become aware of all the pessary options available. So on the whole, a very good session with three good speakers. And I think everybody must have benefited from it. Thank you.
Thank you, Dr. Achla, helping me out to concluding the session nicely. Thank you.
Dr. Renuka, can you introduce the moderators now? And we can start with a very interesting panel now.
Okay, ma'am. With thank you all the chairpersons for giving us your valuable time, and thank you all the speakers for sharing your great knowledge with us. Now we will move ahead with session 2. It is a panel discussion, and the topic is case-based discussion on conservative management of pelvic organ prolapse and urinary incontinence. And to moderate the session, I would like to invite Dr. Sandhya Jain. She is Professor Obs and Gynae, University College of Medical Sciences and GTB Hospital, New Delhi. She is organizing secretary urogynecology, CRV Basics and Beyond 2021, and had been joint secretary NARCHI, Delhi branch from 2014 to 2016. Dr. Amita Jain, ma'am is senior consultant urogynecology, Vedanta Hospital, Gurgaon, and General Secretary of South Asian Federation of Urogynecology and Chairperson of Urogynecological Subcommittee AOGD from 2017 to 2019. Dr. Sandhya?
Yeah, so I want to thank Dr. Geeta and the AOGD team for this opportunity. And is my screen visible?
No, not right.
Is my screen visible?
No, it's not visible.
I will.
You have share your slides.
Your presentation is not visible.
I will stop and redo it. 1 second. It has got hanged somehow. 1 second. Dr. Amita, can you share the?
Yes, I can.
I'm not able to stop. 1 second. Yeah, can I try? Achha, you're doing it. Fine. So now is it visible?
Yes. Yes, Sandhya, please go on.
So yes, I want to thank Dr. Geeta and the entire AOGD team on behalf of myself and Dr. Amita for this opportunity. The topic for the panel is case-based discussion on conservative management of prolapse and urinary incontinence. So we just stop short of surgery. We have to manage these patients conservatively. I have an extremely knowledgeable panel for this. And Dr. Monica Gupta is Professor Obs and Gynae at VMMC and Safdarjung Hospital and has done her fellowship in urogynecology and pelvic reconstructive surgery from UK. The next speaker, the panelist is Dr. Archana Kumari, who is Assistant Professor Obs and Gynae at All India Institute of Medical Sciences and is a gold medalist and has keen interest in urogynecology. And then the third speaker, Dr. Nirja Varshne. She's a senior consultant who's practicing in East Delhi and has been and has worked in many government hospitals in the past in Delhi, including Aruna Asaf Ali and then Hedgewar and the IBS hospital with a lot of experience. And the next speaker is Dr. Uma Rani Swain, who's a senior consultant at Max Super Speciality Hospital. And she has organized about 15 urogynecology live operative workshops and has received Best Award for high uterosacral ligament suspension at RCOG. So, and Dr. Rebecca, we have heard today, and she's a practicing physiotherapist at My Physio at Greater Kailash 2, and has done her PhD on the thesis topic characterization of the sensation desire to void in individuals with and without overactive bladder. So I welcome all my panelists, and without delay, we just start with our case 1. So she was 32 years old, second gravida para 1, who presented at 16 weeks of pregnancy to the OPD with something coming out of her vagina for past 1 month. She also had difficulty in passing urine for past 15 days. She had one uneventful vaginal delivery 6 years back, after which the prolapse had appeared, and she underwent sacrospinous hysteropexy around 3 years back for that. She said that she was very, very uncomfortable, and at that time did not desire another child and just wanted relief of her symptom, and she underwent this surgery. And then she had no prolapse at the time of this conception and no comorbidities either. Next, please. So her general and systemic examination was essentially normal. The BMI was 20, which was normal. On local examination, her cervix was 3 centimeters outside the introitus and the cervical os was closed. She was stage 3 POPQ classification with the point AA at +3, AP at +3. Then she had BA at, BA was at +3, BP was at +6. There was cervix was at +6, and then D at +2. Genital hiatus was 0.5, perineal body 2, and total vaginal length was 9. So she was stage 3 POPQ, and ultrasound she had got with her, which showed a singleton pregnancy at 15 weeks, and cervical length was 45 mm. So my first question is for Dr. Archana Kumari. Any specific investigation needed for this patient now for her presentation and urinary symptom?
Yeah, as is very evident from this, the patient has complaints of something coming out of vagina along with difficulty in passing urine. So there is a risk of urinary retention, and there is risk of, because of urinary stenosis, there can be increased risk of UTI. So I would like to go for a urine routine and a microscopy, as well as a urine culture and sensitivity test. And to find out about the post-void urine, I would like to go for an ultrasound KUB to know the post-void amount of post-void urine.
Okay. Okay. Any other investigation would you like to do for her?
Yeah, we can go for uroflowmetry in this patient, because the degree of cystocele, as evident from the POPQ classification, is quite high. So it would be better if we go for uroflowmetry to find out the type of difficulty in passing urine.
Okay. So her urine routine was normal. Post-void was 300, and Euroflow, as you rightly said, can supplement our workup for this patient. It's an absolutely non-invasive technique, and the max peak flow rate was around 8 ml per second, as against a normal of 12 to 30. So definitely there was voiding dysfunction. So the next question is for Dr. Monica. So what could have been the causes of prolapse in this patient and the cause of voiding dysfunction?
Well, as you said that, this patient had earlier also, because of an uncomfortable prolapse, she had underwent a conservative surgery for, which is the uterine hysteropexy, which you had said. So maybe that previous delivery would have led to, damage to the pelvic tissues in the fascia, supporting fascia for the uterus, leading on to the prolapse. And also, as regards the voiding function, of course, the degree of cystocele right now is appears to be large, and there may be some amount of kinking and excessive bladder prolapse, which may lead to voiding dysfunction. though there has been a history of sacrospinous hysteropaxy as a surgery, but by and large, many studies have showed that it doesn't lead to that much of a voiding dysfunction. But supra added, I mean, this pregnancy added on to that previous cesarean, previous surgery, and this huge recurrence of cystocele may be the culprits here in this case, causing the
absolutely right. Absolutely right. So she has an inherent defect probably in her tissue, her tendency to prolapse. So in pregnancy, two kind of prolapses can be there. One, where the tissue has inherent defect, and since she has previous prolapse, there is a problem with tissues and it has now recurred in a second pregnancy. The other class of patients, how tissues are absolutely fine, but due to pregnancy physiological changes and uterine pressure, sometimes they suddenly present in third trimester with the prolapse. So the outcome of the two would be different. And probably this kind of prolapse, the latter one where it just came out in third trimester, as soon as she's delivered, and it will go back. But for our patient, probably it will keep on coming as she's having subsequent vaginal deliveries. So the next question.
Dr. Sindhu, I would just like to add one thing, that we have not evaluated her voiding pattern even after the first prolapse, because sometimes it could be because of some kind of crush injury to the nerves, the voiding patterns can change. It was mild at that time, probably patient ignored that thing, and then because of these kinds of things, voiding dysfunction can accentuate in second pregnancy because of the prolapse recurrence as well, and because patient is into retention. So we have to actually reposit this prolapse, and then we have to see whether patient is able to void or not, because if there would be a kind of neurological problem or something, probably we can see a difference in voiding pattern. So for Euroflow, it's not only to see that how much she voided, it's to see her voiding pattern, whether she is able to generate a good bladder contraction or not. And here comes also the role of urodynamics.
Yes, absolutely. So the next question is for Dr. Uma. How will you now manage this case? She has come at 16 weeks, she has urinary problem, she has prolapse. So how do you now plan to manage her?
Before answering that, I have seen two of these patients with a very lengthy urethra. The urethra gets...
Dr. Uma, volume, can you just come close to mic? Or Thank you.
Before answering this question, I have two patients where I can measure the urethra is around 7-8 centimeter. It gets stretched out with the prolapse. So it may be as the same as that of the retrofitted gravid uterus when we see in the 14-15 weeks of gestation. It gets stretched out and the cervix also getting pressed the bladder neck. That may be the cause for the obstruction and having high residual urine. And coming to my management, because the patient is primarily the prolapse with retention of urine, we will get her free from retention by giving a Foley's catheter for a few days. And I'll definitely advise the patient to get hospitalized for a few days also, because the management is to repose the prolapse part for the time being. And when we just get her admitted and lie down position, and if possible, it's a little tenderloin position is better for her. And if the cervix is not much of hypertrophy, it automatically slips inside the vagina. If it is not, then with the gentle pushing from below, we can repose the cervix to the vagina. But with that, we have to give her some progesterone to quiescent the uterus, not to have preterm contraction or premature labor. Once, if the cervix is very hypertrophied, we have, for the time being, we have to give some hygroscopic agent like glycerin acrylflapping like that. And 1 or 2 days, it is actually swings and it is automatically replaced. Once the replacement is there with then we can put a temporary treatment for the prolapse is Pessary, anything which suits her, and according to the condition, we have to select the Pessary and the size of the Pessary. Once the Pessary sits in proper place, we can remove the catheter and give a bladder training so that she is happy without catheter, evacuating her bladder regularly. And
so that is absolutely the complete treatment. And so how will you tell her pessary care now in pregnancy?
In Pessary is the same, like we should educate the patient how to remove it. But because he's coming to us every 3 to 4 weeks interval, we can do the things rather than putting the patient into that tax. But when he is coming, like pessary has to be removed very gently and wash it off with the water or some antiseptic and keep it dry. Again, the same pessary can be put inside. Along with that, she can use some of the creams, antiseptic or antibiotic cream locally. And also it can give rise to, during your pregnancy, that's excessive of discharge from cervix also we have seen, and hydorrhea, what is known as. With that also she can use some dry pads, or she can use tissue paper to wipe out the extra secretion. If it is infected, we can give her antifungal locally, or it may not be required for that.
And Dr. Uma, which kind of particular pessary you will think that this patient is?
Commonly, we have a ring pessary with support is best, but even we have seen ring pessary also good for the patient.
Yeah, I think the first choice would be that only. Dr. Geeta has beautifully elaborated. And so the ring pessary with support would be, with the diaphragm preferably, would be the best for her case. So now the next question is, Dr. Rebecca, what preventive measures will you now advise to prevent recurrence of prolapse in pregnancy? And because she has to carry on for rest few more months now with this.
I had to remember to unmute myself. Yes, thank you.
Dr. Rebecca, are you around?
Yeah. Yes, I'm here. Yes, thank you. Okay. Yes. So obviously, this patient also needs to do some
Pessary in situ, yeah.
Yes, some pelvic floor muscle training, because she's had that history of having the prolapse after her first delivery, and now this has happened again during her pregnancy. So this, in terms of managing the prolapse itself and the pessary management, I think this is a fine example where that is the gynecologist's role, and we would only be involved if the gynecologist asked us for some reason to help this patient with self-management, because I think most of the time in pregnancy, the pessary is left in and the gynecologist takes it out and puts it back in during reviews. So only if the gynecologist said to us, for some reason, we also want this patient to take it out and put it in at home, would we have any involvement in that? Otherwise, our role would be to assess this woman's pelvic floor muscles with the pessary in situ, because it gets that prolapse out of the way so that the muscles can actually function better, and start her on a pelvic floor muscle training program to help during this pregnancy, but also for afterwards. And I would also be having a conversation with this woman's gynecologist about the level of daily activity that the gynecologist was happy for this woman to do. So some women are put on bed rest, but of course bed rest has its own set of complications and is to be avoided if possible. And so this idea of relative rest and getting a good match between how much time they should spend resting and how much time they can spend up and about, and learning to use her pelvic floor muscles during any activities that rise intra-abdominal pressure, so that she's getting that counter pressure from beneath. So it'd be a bit of that functional training with her pelvic floor as well as her strength training. And advice for her on how to do things like get out of bed without massive intra-abdominal change and get out of a chair. There's functional strategies you can use to do those things with less effort. We talked to her about toileting position, for example, and if she's having trouble with emptying her bladder because of where that uterus is sitting and that she's got that cystocele, sometimes women can learn to pelvic tilt and move in different ways on the toilet to relieve the pressure and end up with a better ability to void properly.
Okay. Yeah, sorry. Sorry. Specifically, Dr. Rebecca, I want to ask, you want to offer pelvic floor exercises to her.
Yes.
Anything different from a non-pregnant state, or the same kind of exercises? And can she do it with pessary in situ?
She can definitely do it with pessary in situ, and it would most likely be more effectively working with the pessary in situ. And same principles for pelvic floor muscle training in pregnancy as in non-pregnancy, a combination of strength training and what Dr. Karishma called the NAC, or functional training to work against intra-abdominal pressure. So a combination of those two things we would be doing with her in different positions, sitting, lying, standing, getting out of a chair, etc.
All right, thank you so much. Yeah. So we move ahead with the next question.
So Rebecca, I just want to ask you that sometimes patient might feel a kind of discomfort while having pessary inside and having those pelvic floor exercise. Then how you adjust the things that we need to adjust the size of pessary, or we have to, you know, how to deal with those patients who are on pessary and having discomfort while doing pelvic floor exercise, or it's getting out. Like once they are doing exercise pessary, which they fitted, it is coming out. Then how will you, you know, suggest in those patients? How will you manage?
So I didn't get the second part of the question. If what's coming out?
Like a patient is already on pessary and you are asking for pelvic floor exercise. Some patients might ask that they are facing discomfort while having pelvic floor exercise with pessary in C2, or some patients even can tell you that it's it's the pessary is coming out once they are doing
slipping out.
You know, then how, like how will you coordinate with the gynecologist who is treating?
Sure. So I think if it sounds like the size is wrong because she's getting too uncomfortable while it's in, because ideally a well-fitting pessary, they can't feel it at all. So if it seems that the size is troublesome, then I might have a phone call with the gynecologist and see if they'd like to consider trialing a different size. But the other thing that patients can be taught to do is to clean their hands really well and push the pessary themselves if it has started to sit down, because sometimes there's no such thing as 100% ideally fitting pessary. It might be one that does a really good job that sometimes slips down, but you can't go to the bigger size. And so you can teach a patient to gently put it back herself, particularly while she's lying down, and then perhaps do a few bridging exercises where she lifts her bottom up so that gravity helps push it backwards a little bit. That starts to get quite uncomfortable in advanced pregnancy though. So she can learn to push it back and then do her exercises with that. If her exercises are pushing it out, it's already sitting too low, because the pelvic floor muscles, as they squeeze, push it down, and they shouldn't do that. They should actually be pulling it up. So that would suggest to me that it's sitting down too low while she's trying to do her exercises.
Thank you. Okay. So next question is for Dr. Neerja. What other risks can she have for rest of her pregnancy, and how do you prevent these?
So am I visible?
Yes, you're audible and visible as well.
Okay. We can divide them into three categories, like during antepartum, intrapartum, or postpartum categories. Like during antepartum, we can expect that there can be a cervical infection. Patient can land up in spontaneous abortion. She can have preterm labor. Fetal or maternal mortality can also be there. She can have acute retention of urine. She can have UTI. During intrapartum period, if we had not managed her during her antepartum period, then the cervix may be lying outside. She may have edematous cervix. Then that can lead to obstructive labor. She can have cervical dystocia. Then she may sometimes have hysterorexis, and fetal IUD also we can expect. And during postpartum period, we can have again postpartum infection can be there, or she can land up in PPH. And she can, that is all she can have.
Yeah, so you have narrated them all nicely, and she can have premature labor and premature rupture of membranes. Okay, so next up,
Sandhya, can I just interfere here? This patient had a sacrohysteropexy, if I'm not mistaken.
Yes, yes.
Would she be a candidate for normal delivery? And if yes, why? If no, why not? Maybe your panelists or somebody can attend.
Yeah.
Yes, yes. Anybody wants to attempt? Dr. Uma, Dr. Neerja?
Dr. Sandhya,
Yes, Dr. Amita.
Yeah.
Practically, I have two
This
patients.
was our next question.
Yeah.
Okay, actually, this was our next question. So I think let us give it to Dr. Archana, because she can let us see what she says. So how do you counsel this patient now for her mode of delivery? Yeah.
So I think, according to me, the counseling of this patient would begin right at 16 weeks of gestation, about the need to keep a prolapse reduced, because and the use of pessary, the use of pelvic floor muscle exercises, so that the mode of delivery can be decided at term. So in this patient, there is already an inherent weakness which has already been repaired by sacrospinous hysteropexy, and still in this pregnancy there is stage 3 prolapse, for which he had to use the pessary. So according to me, in this patient, we should go directly for vaginal delivery, and maybe repair later in the post when she has already delivered in the puperium, depending on the degree of prolapse. But in any other patient with sacrospinous hysteropexy and who did not have any recurrence of prolapse during pregnancy, in those patients, I would go straight away for cesarean section in those patients.
Yeah, so I think that answers Dr. Geeta's question also. So for mode of delivery, as you rightly said, there is no contraindication to vaginal delivery except for a close watch on the progress of labor, and a senior person should attend to her delivery definitely, because we have to prevent sinister complications. So thank you. And next, so after manual reduction of prolapsed uterus, a pessary was placed for this patient. And after that, she could void without any problem, and cervix did remain intravaginal. And she was coming on regular follow-up. At around 28 weeks, her pessary was removed, and pelvic floor exercises were continued. She didn't need to use it further, because the uterus was already largely abdominal by that time. And at 38 weeks, she had a vaginal birth of a 3.5 kg male boy, and without any complications due to prolapse in her labor. Then her postpartum, again, after a few days, she had this complaint of something coming out, but this time there were no urinary complaints. And now she's lactating, and now she says the family is complete. So the next question is for Dr. Uma. How do you manage her now in her postpartum period with this situation?
Actually, seeing her POBQ, the posterior compartment is the maximum dependent area than anterior compartment. But because of the pregnancy pressure, she was symptomatic so far as her bladder problem is concerned. Now, after her childbirth, during her puerperium and her lactating time, the repeat surgery is definitely mandatory for her. But because of her condition and the lactating time, and because of her hypoestrogenic stage, I will not directly go for surgery, and I'll wait for a few months or years, because of the less of estrogen, the endopelvic fascia, the ligaments are very, very lax because of relaxing hormones also. And also with the hypoestrogenic stage and severe lactation, absolute breastfeeding, the uterus is also involuted. So my assessment will be very erratic, and I will definitely defer her treatment, surgical treatment. And now I will definitely again put her in the suitable pessary to keep it for a few months. After cessation of lactation and feeling the muscle power and the ligaments and all, it has improved during her pessary treatment as well as pelvic floor training program, and I'll definitely go for surgery. The surgery is what should be the surgery. The vaginal or abdominal are in front of us, because it's a recurrent prolapse. Definitely the same sacrospinous will not be addressed upon, and abdominal sacrocolpopexy or pectopexy can be a better suitable surgery for her. And also vaginal high uterosacral ligament suspension is equally good.
Okay, so I think very valid points.
Again.
Yeah.
Yeah,
so she has failed a vaginal procedure. We have to really rethink now and replan for her. So can we move next? So Dr. Rebecca's question has been answered by Dr. Uma well. So I think we can move ahead, Dr. Amita. Unmute, please, Dr. Mita.
Thank you, Dr. Sandhya. And so I'm very thankful to all panelists for giving a very good insight over the role of conservative management in prolapse. So now our second case is a combination of prolapse and incontinence. She is a 74 years postmenopausal lady. Her BMI is 32. For last 1 year, she's having problem with frequency in daytime 10 to 15 times, in night 3 to 4 times, and she is experiencing urgency, and sometimes even she's leaking while having urge. She is complaining of a vaginal bulge with difficulty in passing stool. Sometimes she has to deposit that bulge to complete her act of passing stool. She has already given 4 vaginal births which were uneventful, and the last one 45 years back. She is presently suffering with glaucoma since last 15 years, and also she's complaining of constipation and allergic bronchitis, for which she is taking on and off irregular treatment. She underwent sacrospinous ligament fixation with simple facial repair of cystocele for apical prolapse and stage 4 cystocele 10 years back. And the cystocele was giving obstructive symptoms at that time. Now her son stays abroad and cannot travel in near future, so she is currently reluctant for any further surgical procedure. And on local examination, she is right now having recurrence of cystocele, but this time only stage 2, but the high rectocele is stage 3 with atrophic changes in vagina, and there is no even occult stress urinary incontinence. So this is the position right now. So Dr. Neerja Vashne, how will you proceed in her case? And before that, I would like to ask Dr. Neerja, what significant you find this history of having this recurrence of prolapse in this patient?
She is having prolapse recurrently because of her all the high risk factors which are leading to prolapse, like constipation, chronic bronchitis, and high BMI, multiparity. All these factors are leading to her recurrence of prolapse, and moreover she is taking irregular treatment for her bronchitis and constipation, which are all of these factors are aggravating her symptoms. So for her, and now she is reluctant for surgery because she had a very bad experience of past when she could not get herself cured by the surgery. So first of all, we should counsel her about her weight reduction. Then we have to counsel her taking regular treatment for her constipation and bronchitis. And then we have to, though it is, like you said, it's very difficult for weight reduction for her age. And then we have to go ask for her bowel habits, and we have to take her bladder diary. We have to ask her to maintain her bladder diary. So for bladder diary, we'll ask her when she's getting up, when she's going to sleep, how much time she's taking the liquids, then how many times she has to go, the volume of urine she's passing, history of any incontinence, then whether she's using any pads. Then for her food habits, we have to ask whether she's taking any diet which leads to her urge, like alcohols or any spicy food or any caffeine and all these things. So we have to maintain we can counsel her to maintain the bladder diary. We have to pinpoint her food habits which are leading to her these problems, and these are the things we can do.
So Dr. Neerja, just to interrupt, sorry. One point I just want to highlight that the last surgery was not bad because it was 10 years back, and now she's having recurrence for last 1 year. So I think it's because of her neglect, because probably we did surgery, but we never tell patients sometimes, or even patients cannot follow that. She has to avoid constipation, she has to avoid chronic cough, she has to avoid weight gain, because nothing can be permanent. I always tell my patients that even God has made you perfect, but it is because of the pregnancy and delivery. Now you are not getting to get pregnant or delivery, but at least you have to avoid heavy weightlifting, weight gain, constipation, and chronic pain, chronic cough. So that's relevant. Now we can relieve some symptoms by just changing bowel habits, like high fiber diet can be asked, and even patient can be asked to have, kind of some management for the constipation. Yes, some investigations are required. We have done investigations like routine and culture, which was normal. Ultrasound we did, and we found that post-void residue was just 50 ml. And obviously we asked for the bladder diary, very well explained the diary, how it should be maintained. So the diary
also have a bladder neck ultrasound also, and if she can afford, we can ask her to go for uroflowmetry, and filling and voiding cystometry can also be advised to her later on if we think it is required.
Yes, ma'am. But I think to start with the initial conservative treatment, we don't need these kinds of, the basic things. I think bladder diary is the first essential thing which can tell a lot of things, like I mentioned in the slide. It can give us a very, the fluid intake pattern, the voided volumes, which is the highest, which is the lowest, how is she doing the whole of the day, which irritants she's taking, when is she leaking, what is provocating factor. All these things can be seen if you can just tell patient how to maintain a good bladder diary. So I am just showing my website where I have given all the videos how to maintain bladder diary in Hindi and English both. So it helps patient. I don't need to tell them again and again, because patients forget if they go home. So this is the example of bladder diary. So you can see that this is the bladder diary of this patient. And now my question to Dr. Archana, what is your inference based on this bladder diary? I'm showing you bladder diary again. Please let me know that what is your interpretation from this bladder diary?
So from this bladder diary, it is very evident that the urinary frequency during daytime is quite high, 10 to 15 episodes per day. And the urinary frequency during night time is 3 to 4 times. And the largest volume that is recorded in the diary, that is the functional bladder capacity, is around 200 ml. And so we can see that rest of the time she is voiding just small amount of urine, 80 ml, 60 ml, 150 ml. So the increased voiding frequency is associated with small voided volume during the daytime, and that is associated with urgency. And so this points out that this urgency is because of the overactive bladder, and this is precipitated by the intake of coffee, tea, cola. And so these leakage episodes are related to the precipitating factors like these. So maybe restriction of these precipitating factors and restricting the amount of fluid that she is taking during the night time to take over the night leaks and the nocturia will help this patient.
So yeah, very well explained, Dr. Archana. One thing I want to highlight, that we can see that there are two voided volumes which are, and the highest is at the time of morning once she is getting up. Probably it is also related to prolapse, because in night the prolapse is reduced and patient is having a better retention, because it has been seen that with, especially cystocele and these kinds of prolapse, there could be accentuation of urgency. And that's why probably the patients are going again. And we have to rule out very smartly in these patients, whether with a prolapse which is getting more and more in the evening time once patient is standing and walking, then probably whether patient is able to void completely or not. So one PVR of normal is not enough. That is very, very important. And we have to see these patterns. That's whether patient is going into partial retention once the prolapse is coming out. So my next question is to Dr. Umarani. What will be the initial treatment option, madam, for in this case? Like how you will start the conservative and other treatments?
For that, I should tell that the patient is very smart not to take water, but take all other liquids which is irritate her bladder. One. Second, as unlike this morning polyuria, usually you see in our practice, in our life also, we go 2-3 times in the morning hour. After 10 o'clock, the frequency die down actually. The morning hour may be mobilization and our exercise pattern and everything, changing of our pattern from sleeping to mobility can increase our frequency. So also this patient has. Coming to the treatment part, because she is taking all irritants, gradually I should I have a lot of things to homework for the patient. Apart from her weight loss, which is not possible, and she will not listen to me, I know. Reduce this irritant. In that place, she has to take water, and the daytime water intake should be adequate to give rise to full thin stream of urine. And this, if the thick urine is there, it irritates, and also these beverages. Second homework is to how to have a urge suppression and all. Practically, I want my patient to go and spend at least few hours outside, and to very look of the toilet is also very compelling to go to the toilet more and more. Third, even during urge time, she can do something to distract her mind, or she can do pelvic floor exercises. What the next step is to direct down her urge part, and she will not rush to the toilet, rather than in a good pace, normal pace, she has to attend the toilet. Fourth one is she has to do Kegel exercises, and I have to make sure that every alternate week, if I call her, if she is not able to understand the muscle, which muscle has to be exercised, then putting my finger in a supine position, I can see that whether she can squeeze my finger, and other than and also not activating her abdominal thigh and gluteal muscle, it will be very nice to have an early recovery from the problems.
Thank you, Dr. Uma. I think you very well highlighted that we have to start with the conservative treatment, and it can help a lot. So the fluid intake, which is very, very important, patients should sometimes, in our scenario, it has been told to the patient they are taking for ages 5 liters, 2 liters in morning. They think that it will avoid constipation, which is a kind of myth, because if you are drinking a lot in the morning time, it will only increase your frequency. It should be adequate. It shouldn't be less, as you very well said, that if it will be less, it will produce more concentrated urine, which will be rather irritant to the bladder. So again, will increase the frequency. So it should be adequate in distributed form. So patient, if I always tell my patient that if you're taking a good 8 hours sleep, you have to avoid drinking 2 hours before sleep. So 10 hours are left. In 14 hours, you have to take 2 liters. So it is around 120 to 150 ml per hour. So if you're taking 1 glass of milk, then please avoid taking anything else in that hour. So in this way, they have to distribute their fluid intake. And obviously, like Dr. Nee just highlighted, that they have to avoid any kind of irritants, which could be caffeine, even the chocolates and all, because it's having content of caffeine. So these things are important for fluid intake. Yes, you told Dr. Uma that how bladder retraining helps, like they have to do a timed, gradually they have to increase the interval between they are voiding. They have to use those urge control techniques you just explained, like bladder, like distraction of mind. They can use their pelvic contraction and many other things to control over their voiding. So these things can be, they can have weight reduction, constipation avoidance. All these things can help, which are called self-management techniques. And all these behavioral techniques, even the urge control techniques, should be used at least for minimum of 6 weeks before jumping on anything else. You can't say that nothing is working if you have not used it adequately for at least 6 weeks. So now my next question to Dr. Rebecca, I think it was very beautifully covered by even other speakers, that how the pelvic contraction help in controlling the symptoms of urge. But I think Dr. Rebecca can highlight it again, that how these pelvic floor contraction therapies help in symptoms of urgency, because it is particularly a myth among gynecologists that pelvic floor exercise is only required for distress incontinence or prolapse, but it helps in urge incontinence as well. So Dr. Rebecca, can you please highlight this thing?
Yes, sure. Thank you very much, Dr. Jane. And I think there's quite a bit of difference between the training for stress incontinence and urge incontinence. And so very briefly, the main ideal with someone who has urgency incontinence is to teach them, firstly, to be very confident they're correctly contracting the right muscles, that they're doing that without breath holding and that they can hold their muscles and walk at the same time. That's essential. They will not help themselves if every time they contract the pelvic floor muscles, they hold their breath and can't walk and hold. So it's about coordination training, and that's largely what we'll do with them. You can also use quick contractions as a sensory distraction. So a lot of people will find that if they do some little fast contractions, the urge sensation dies away, and that buys them a little bit of time. But it has to be contraction of the right muscle. It doesn't help if they're contracting their adductors or their tummy muscles instead. So it's about accuracy, it's about isolation of the muscles, and about brain training along with pelvic floor training, about that urgency control. And even if it's not about distraction, it's about them not being frightened of urgency, learning to gain some confidence over that sensation.
Thank you, Dr. Rebecca. I think that that was the slide from Karishma where she has shown that how, you have to use those fast contraction just before the peak of your urgency. And then you can actually reduce that bladder contraction. So these things are important, how to, help your patients, how to use these urge control techniques in a right way. Then only, otherwise, it's very easy to say that everything is not working.
Dr. Amita, I'm sorry. Can I butt in here? Can I butt in and ask one question to Rebecca?
Yes, ma'am.
So it's a corollary. Rebecca, thank you very much. It's a corollary question about the pelvic floor contraction in urge urinary incontinence. Supposing I were to ask you, how does pelvic floor contraction help in control of fecal urgency or urgency or flatal urgency? Is it the same pathway or is it something different?
That's a really good question, Dr. Medirata, and I think we don't actually have scientific data to tell us how the pelvic floor muscle contraction changes urgency. We don't have that yet, so we're relying on our theories. And with fecal urgency, my feeling or my theory, favorite theory, is that our brain knows our rectum can't hold liquid, and many people feel urgency more with loose type stools, or if they have an insufficient sphincter. So if there's lack of sphincter control, I think our brain knows it, and it says you get to the toilet right away or you're going to leak. And so gaining control of closure, so that closure of the anal sphincter and the puborectalis, making that kink in the puborectal angle, the pulling forward. So you get the closure from the sphincter and from your puborectalis. And when patients know they can shut their anus, the urgency tends to go away. And it's similar with bladder. And one of our theories, of course, with the bladder is that by contracting your pelvic floor, you inhibit detrusor overactivity. But we know that only about half of patients who have urgency have demonstrable detrusor overactivity. So it's not always about that. And there's some lovely studies of MRI function of the brain that show different anomalies in brain function in women with urgency urinary incontinence. Some have excessive activation of the anterior cingulate gyrus, and others have deactivation of the prefrontal cortex. There seems to be quite distinct groups, and they respond differently to pelvic floor muscle training. So it's quite interesting. It probably does different things in different people. But I think when a patient understands and has great confidence that they can shut their sphincter, whether that be anus or bladder, urgency tends to lessen. So that says there's a big role for what's going on in the brain.
Right. So if there were two sets of patients, one with urge urinary incontinence and one with urge, say, fecal, she just, the shit just comes out. She has an urge before she reaches. So if you were to offer your pelvic floor contraction, what my mind says after listening to your theory is that the urinary urge lady will benefit more than that, because that is more of a sphincter. Maybe she had a delivery and the sphincter got torn. You see?
Can I interrupt?
So the fecal.
I think here we need a kind of, assessment. What is the reason for her urgency during, even
fecal urgency.
fecal urgency. So even, sometimes I have taken help of colorectal surgeons. Few are very good in that. They do manometry, and there are different theories for this fecal urgency as well. So I think if it is at all because of the, weakness of the pelvic floor, then only
it will benefit.
Yeah, it will benefit. But if there would be any other factor, then probably
anatomical tear that would need addressing. Thank you, Amita. Sorry for butting in. Sorry.
Thank you, ma'am. So I just want to ask Dr. Monica Gupta whether you have anything to fill in the blanks regarding urge control techniques.
Well, Amita, much has been said and very, very comprehensively covered by Dr. Uma and Rebecca. But just a reiteration that for the fear of just leaking too often and any time with this urge, these patients kind of develop that tendency to rush to toilet very often, and in turn, as a vicious circle, they tend to make their bladders hold lesser urine. So this, I don't know how much the patient in question, 74-year-old in our scenario, would listen to us regarding any of the behavioral therapy, but much time need to be spent with these patients.
Yeah, that's very important.
There is no
time you will spend, they will listen to you.
Yes. So you need to explain each and every point when you are sitting with them, why this thing being told to them is important in their behavior, and how is it going to affect eventually their bladder habits. So in order to kind of let the bladder know that it has to hold more urine, as you said, timed voiding, yes, rescheduling of voiding patterns, yes, double voiding at times, yes. And she needs to be made aware that if she was rushing to toilet maybe at every hour interval, then she needs to control that urge. She needs to be told. She needs to add maybe 15 minutes at a time to that interval. And then slowly, gradually, she needs to be told that this is the time till this time she needs to be holding the urine. And she needs to engage in other things like she's a 74-year-old, she must be having grandchildren at home. She can engage in their playful activities. The moment she thinks of some urge, distract her mind, listen to some music, get into maybe vegetable cutting or whatever, just to kind of suppress the urge. And of course, any kind of that mid-urge thing should not compel her to rush to toilet. So that's all. These are the various few things. She can sit on the edge of some, hard surface, maybe edge of the chair or arm of the chair. Whenever she feels that urge, wait for 60 seconds till the urge suppresses. Things like that definitely work, but you really need to spend time with your patient.
And also it is very commonly seen, madam, even elderly lady will be put in a bedroom which is having attached toilet.
Yeah. So she needs to rush to toilet all the time, which needs to be curbed, and she needs to be more involved with the other activities in the house.
On the contrary, we have seen. On the contrary, we have seen patients. They have actually got fracture because of the slip, because they are rushing to the toilet. So they never come up with, because of the problem of incontinence urgency. They came once they have got the fracture, then probably that orthopedician told why you rushed, and then he comes to know about the thing that she is having problem of urgency, and then they are coming. So this is the stigma. And sometimes they are going to their private practitioner and they are just telling it is with age, nothing can be done. So it's never happened, so
that's why we need to spend a lot of time with our patients, especially these clients.
Yes, that's true. So again, my question to Dr. Rebecca, how will you help her if she is not able to recognize or adequately contract her pelvic floor muscles? I know Karishma has told many things about biofeedback and electrical stimulation, but I just want to know from you that before that, what will you do that she would be able to recognize? Because, she's 74 years lady and won't be very compliant, won't be very, so you have to do something to make her understand, and even at home, what she can practice to understand whether she is able to do it right or not.
Sure, thank you, Amita. And yes, there's many things we do before resorting to biofeedback and eStim. So I start with a pelvic model that is 3D, and I teach her where her pelvic floor muscles are, and she uses her own hands on her own body to work out where they are. She must have an excellent mental picture of where her pelvic floor muscles are and what they do. So that's what I start with. And then I use my fingers on her muscles, so via vaginal examination, my fingers on the relevant muscles, using little tapping or little stretching techniques to help her be aware of where those muscles are and what they do. And I use my verbal feedback to encourage her when she's got it right, or to try different cues until she gets it right. And we've got good research showing that pelvic floor muscle activity changes with different cues, different things happen. So I use those techniques, and I use training techniques for motor learning. So I won't go into that in detail, but also the most essential thing is that before she goes home to practice unsupervised, she can accurately tell me, I'm contracting now, and now I'm losing it, and now I've lost it. So that I know she understands she can do her exercises properly. And look, I've had so many elderly women who have excellent body awareness. And so just with a little bit of training, they get the idea really well. So it is possible to teach them to do their exercises well at home.
Very well said, Dr. Rebecca. Like many of the patients are coming to me because they have just been written Kegel's exercise, and they are just telling me we are not able to do.
I don't know what to do. Yeah.
So we have to tell them very, few points that you don't need to take extra time for this thing. You can combine it with any other activity like brushing teeth or doing anything, the day-to-day activity, because it can be done in any position, lying down, sitting, standing. And yes, we have to make them realize what is contraction, what is relaxation. And they don't need to, we have to see whether they are holding breath, they are using abdominal muscles. They can initially put a hand on their belly to just confirm they are not contracting their abdominal muscles. We have to see, we have to tell them again. I think these things are important before just asking for a biofeedback or, electrical stimulation. I'm not going into detail of those things. Though these things also help. If patient is not at all to, contract, not able to understand, I think biofeedback, these kinds of vaginal cones and these are kinds of things are very helpful for especially those patients who are not able to contract at all their pelvic floor muscles, despite of your all kinds of efforts. Then probably if they are able to hold their vaginal cones, and they can increase their weight of the vaginal cone, and in this way they can. And biofeedback even can give a visual impression, as very well covered by Karishma. So now, Dr. Neerja, again, you have covered regarding the bowel things. So how will you address her bowel symptoms, and what kind of education and what kinds of advice you will give to control over her bowel symptoms?
We'll have to ask her to increase her fiber in her diet. We can advise her to take stool softeners or bulking agents, laxatives, which can improve her bowel symptoms. If in spite of all these measures, she is not able to improve her bowel symptoms, because as we had elicited in the history that she had to push the vagina to evacuate her bowel. So she might be needing vaginal pessary because she has a high rectoceal. And because she is having vaginal atrophy as well, so it will be better we address her vaginal pessary with local estrogen, so that her vaginal atrophy doesn't deteriorate. So these measures we can do for her.
Okay, so going to the next question. So what could be the complete role of estrogen in such case, Dr. Archana? Like Dr. Neerja mentioned, once you are putting a pessary, then you are thinking of vaginal estrogen, but otherwise, what could be the other roles in this case? How it could be for benefit, and sometimes it's not getting kind of, there could be some side effects as well. So please elaborate that, Dr. Archana.
Actually, estrogen is something, there is a say, we say, absence makes the heart grow fonder. So estrogen is something like this in the postmenopausal women, and so estrogen supplementation, it has been seen to exert trophic effect on the urethra, the mucosa, the submucosa, the pelvic floor, and even the periurethral tissue, collagen. So it basically improves the vasculature of the bladder neck, mucosa, and the trigone of the bladder, along with improving the urethral sphincter function. So basically, it has effect both on the bladder, both on the urethral sphincter function, and plus estrogen also has alpha adrenergic activity, and so that takes care of the overall urinary control and improves the symptoms of urge incontinence in these women. So vaginal estrogen are very safe, and they don't have any systemic side effects of thromboembolism and endometrial hypertrophy and breast cancer, and so they are very safe and are especially helpful in these patients with atrophic vagina.
Okay. And Dr. Archana, what are your views of using oral estrogen?
Yeah, oral estrogen can also be used in such women, but matlab the compliance and the effect of local vaginal local estrogen therapy is best in these women.
So okay, so if there are, like, she's a postmenopausal lady, and so there could be a role of vaginal estrogen to decrease the symptoms of atrophic changes, which are usually burning or pain or dysuria and recurrent UTI sometimes in this patient, apart from urge incontinence. So there is a role, and it helps in controlling the symptoms of urge incontinence as well. But regarding oral one, it has been said that sometimes it has been seen that it can worsen. So if you're using it for some other indications, okay, but don't use it for to treat particularly the urge incontinence. So that's the broad idea about using oral estrogen. Dr. Monica, now we are coming to the stage when patient is telling that there is some improvement, but she wants complete cure. So probably you have to tell her about oral medical management as well. So what could be your choice, particularly in this patient, Dr. Monica?
Anta's point is that there are two schools of thoughts. Some people say that even while you have started these behavioral therapies and bladder training and all, you can coexistently put them on oral medication as well. But though the robust data is not available saying that both of them started together would be, effective, or monotherapy followed by dual therapy. But then, yes, having said that, if conservative management had been tried, at least a proper, a timing of at least 3 to 4 months should be given before we can think of adding on to the, the medical therapy.
So now we have to switch on medical therapy. So what would be your choice?
Yeah. So the traditional agents available are the antimuscarinic, anticholinergic, and the beta-3 adrenoceptor agonists. But in this particular case, since I believe you had mentioned that she had I think glaucoma, she had acute glaucoma, and I think chronic bronchitis as well. So in such patients, we will definitely avoid antimuscarinics, and we would like to put her on beta-3 adrenergic agonists like mirabegron. And but yes, with a caution, this patient is again an old age, a 74-year-old lady, and mirabegron is documented to have an effect on the blood pressure as well. So with a close watch on her blood pressure, maybe we can start her on this medical therapy.
So very well said. Yeah.
Grams per day.
Yeah. So anticholinergics are there, but probably in this particular patient, you well told, like she's having glaucoma as well as constipation she's having. Bronchitis can cause dry cough, or all these things can aggravate the symptoms and will lead to poor compliance. So probably beta agonist is a better agent for her, specifically once
even Dr. Mita, even M3 specific receptor specific antimuscarinics, they also have anticholinergic effects, like, so even those cannot be given, like solifenacin and derifenacin.
There is an absolute contraindication in this patient of
even those class of drugs.
Like, because constipation, dry mouth we can manage, like we can have an active treatment of constipation. dry mouth, we can, but not glaucoma. If patient is having irregular treatment and active glaucoma, these are the candidates with their, you can see in this slide, this is the absolute contraindication. Pregnancy.
That's very important, yeah.
So uncontrolled narrow angle glaucoma. So if glaucoma is controlled and managed, then probably, but once we are having a better alternative and she is not having hypertension, she is not a candidate of cardiac disease in past, mirabegron is quite safe. And now even the most latest guidelines tell that yes, you can use it as a first line medication. You don't need to first use anticholinergic, though you can combine two medication if patient is refractory to the monotherapy. But to start with, you can utilize mirabegron as a first line therapy. So this will be the choice of medication in this patient. Now, just to end this panel, just Dr. Uma, tell me when will be the role of urodynamics in such case? Is this case scenario, when will you think that urodynamics should be done?
Unfortunately, this question has been put to me when the expert is you as a moderator.
No, you have attended my.
And before that, I tell you, many of the patient, elderly, younger age and all, with frequency, urgency, all the medical professionals are start with mirabegron, no behavioral activity, nothing. And now this medicine is becoming resistant to them. They will show all the medicine and with mirabegron in a bunch. Okay, it's very, very common. And our representative also very pushing these tablets for their own benefit, but it is really pathetic. Yes. And coming to urodynamics, I feel, because I'm not doing much of this, I just depend upon the urologist. But when there is a lot of confusion in your mind to come to a conclusion or to have a diagnosis, where the sign symptoms doesn't match, when your sign symptoms with your diagnosis is mismatching, and second, if it's a failure case of your own treatment, thinking that it's an urgency but it's come out with something else. If it's a complex urinary infection, urinary incontinence like mixed urinary incontinence, which is predominant, which is not suppressive, and other than that, few of the patient I also sent to you, Amita, that they always dribble. They do not go to toilet. They always dribble. They have given up the idea of putting pad also. They prefer to wash their undergarment as well as clothes rather than putting pad. They're always wet. In those cases, we feel there is some neurological component is mixing with that incontinence. In those doubtful conditions, we should put this patient for a urodynamics.
So very well said, Dr. Uma. If you have used your treatment and patient is refractory to that treatment, if you said that signs and symptoms are not matching, prolapse in this patient, because prolapse is there and it can complicate the thing, like it can give us some voiding dysfunction as well. In these kinds of case scenarios, probably there could be a role of urodynamics. Few things very important before going for urodynamics. Please stop all medication 3-4 days before, especially which can affect bladder, because otherwise you won't be able to get a basic picture. Constipation should be actively treated. Otherwise your patient will sit on the seat and will say, can pass even sometimes a stool at the time of voiding cystometry because she is into stress. So bowel should be emptied before this test, and urine routine and culture should be done before the test. And the last thing is that you should encourage patients to not to use their abdominal pressure while doing the voiding. So these things are very important particulars while doing voiding cystometry. So kabhi aap apne aap se bhi bhejte hain, you are indicating to go to a urologist. Please brief these things beforehand to the patient. Otherwise, there won't be benefit to the thing.
One is urinary infection. Second is constipation. Third is.
So yeah, you have to stop medication. Otherwise, under the effect of medication, the report of urodynamics won't be that full. So these are the important things you have to tell. If you are even referring this patient for urodynamics to somewhere else, these things should be addressed. So these things are the important. And this is the urodynamic report, and where you can see, just for those who are not very well was with the urodynamics that this blue, the dark blue is the total pressure of bladder along with the abdominal pressure. The red one is the abdominal pressure. So once you will subtract it from the total pressure, you will get the actual bladder pressure. And here you can see during filling phase, it should be completely, straight line. But when you see these kinds of spikes, this is the, detrusor instability. And you can see even with this spike, patient is leaking. So this is a very, clear picture of overactive bladder or detrusor instability. With this, I am ending this panel. I'm very, very thankful to all my panelists for giving the, a very clear picture of how to deal prolapse or incontinence in a conservative way. It's a very, very important thing, especially once we have already faced Corona, when we are not able to do anything, just conservative. And then we come to know that there is a role of conservative. And I think you all agree. Thank you, everyone. Thank you, Dr.
Congratulations,
Thank you so much.
Dr.
Thank
Amita.
you all.
And sky is the limit for you, Dr. Amita. And I hope we will be more educated and more knowledgeable with your this current position.
No, I cannot do anything alone. I need support of you all. We have to take this urogynecology to heights. We have to start our training programs. We should have everything at our own place. We don't need any kind of, trainings or something from outside.
Leader is the most important for a movement, isn't it?
I agree with that, Dr. Amita and Dr. Sandhya. I just want to say that you've done an excellent job and you very well rounded off our today morning's program. And I'm extremely grateful to my Urogyne subcommittee team. Everybody, I mean, hats off to you. I'm, proud, privileged to have associated with all 12 of you. I'm extremely grateful to God for having given me this opportunity to head the Urogyne committee. And I think with all of you, I again reiterate, we will go to great heights and long live AOGD. Thank you so much.
Geeta, I would like to say just one few words.
Yes,
Dr. Amita, I think we should have the team of the physiotherapy as well as the urogynecologist, and whatever we need for the total urogyne team should be at every center or at least few centers in the Delhi where we can, look after the patients. They need these type of the services. And plus the PGs nowadays, they should be posted and they should be trained for this urogyne thing, because they have to learn ultimately all these things, and this should be the part of their curriculum.
Yeah,
so I agree.
Sending our PGs, we are sending our PGs to urogyne clinic in our hospital as they go for rotation. We're also sending them to urogyne clinic.
Yeah,
so that
definitely.
they are getting some idea, not so scared of urodynamics now. Otherwise, urodynamics is something, pata nahi kya hai, kind of.
Yeah.
Even physiotherapy, Chandra, you are right. We must have physiotherapy backup, because there is, as Rebecca has pointed out, and Karishma in her beautiful lecture has pointed out, there is immense scope for that. Before you put the knife on the patient, I think there was a study which Rebecca pointed out, 40% became all right. I think 30%, Rebecca, 30% became all right.
More than 30%.
Yeah, Karishma told us that they didn't need. And as Amita said, in the COVID times, we have been treating patients. And as I was telling you about the study which I found, there was a 1 centimeter decrease in hiatus. The women who are using Pessary for 3 months, after 3 months, the perineal ultrasound showed that there was a reduction in the hiatus.
By 1 centimeter, more than 1
centimeter, which is tremendous. So I think there's a lot of scope for A, research in this field, and B, an encouragement by us as a team of urogynecologists of Delhi to all PGs and via AOGD. I think Dr. Achla is on our side. That's the best thing we can ask for, that we must spread this knowledge and this message of conservatism more than surgery.
And Dr. Geeta, as soon as in front of the patient you say there is this option is also there.
Yes.
And they become very happy from here to here, all the smile on their face. So actually they always opt for the conservative management rather than the surgical. Surgical is the last resort.
Absolutely. Thank you. Thank you, Dr. Achla.
Yeah, let me take this opportunity to invite you all for the AOGD annual conference on 19, 20 and 21st November. I want you all to be there.
Yeah, absolutely.
Thank you. And we had
Absolutely.
almost 64, more than 64 attendees, Dr. Achla.
Yeah.
So Urogyne is a
68.
hot topic.
We have a session of Urogyne in conference also.
So today's topic was Dr. Geeta's brainwave, and she's always, she's amazing in organizing these things, and she creates a very wonderful topic. She always choose wonderful topics and practical topics.
Practical. Chandra and Renuka have been my pillars always, and I thank you and take leave from everybody. Thank you so much. Thank you, Shivam.
Bye-bye.
Thank you,
Thank
Dr.
you so
Achla.
much.
Thank you, Team Urogyne.
Thank you.
Nice.